Hong Kong. I appreciate your contribution to exchange of ideas, and I wish you a very pleasant and enjoyable stay in our city. Thank you.
Thank you, Professor Chant. Next, let us invite Professor Samuel Wong, Director of the JC School of Public Health and Primary Care, CUHK, to deliver a welcome message for the event as well. Professor Wong.
Thank you. Professor the Honorable Chung-mau, Mr. Henry Fan, Dr. Ronald Lam, Ms. Shelley Lee, Professor TRISNANTORO, Professor Francis Chen, Professor EKO, distinguished guests, ladies and gentlemen, good morning. On behalf of Jockey Club School of Public and Primary Care and the organizing committee of the Regional Knowledge Events on Health System and Community Resilience, it is my great pleasure to welcome you all to this knowledge event. I would like to express my sincere gratitude to all of you, a diverse and knowledgeable group of individuals who come to share their vision and experience to advance the well-being and health of the community locally, regionally, and globally. As mentioned by Dean Chant, this regional knowledge event brings together participants from more than 10 countries and places to share experience and insights on key strategies and innovations in response to the control of the COVID-19 pandemic. Many of us have been looking forward to having face-to-face exchanges such as this to discuss on the health system and community resilience, drawing upon global experiences. We are honored to have Dr. Ronald Lam, Director of Health of the Hong Kong Special Administrative Region, and Professor Teodoro Hibosa, Secretary of the Department of Health, the Philippines, as our keynote speakers. Additionally, we are privileged to have Professor the Honorable Chung-mau, Secretary for Health of the Health Bureau of Hong Kong Special Administrative Region, to deliver welcome remarks at the opening ceremony. This event serves as a platform for collaboration, innovation, and exchange of ideas, bringing together renowned experts from various fields, including academia, research, policymaking, and healthcare practices, to share their expertise and insights on lessons learned from country responses to inform policy for health system resilience in the face of future public health threats, focusing on 3 themes, including health system resilience, operational resilience, and also community resilience. I hope this regional knowledge event will spark discussion on how the challenges brought on by the pandemic can lead to the enhancement of preparedness, readiness, and response of health system, and participants can share important lessons learned during the COVID-19 to enhance health system resilience in the face of future public health threats. I'm sure all of you will seize the opportunity to network with fellow professionals and exchange knowledge to drive positive change in the field of public health. Last but not least, I want to express my special gratitude to Professor EKO and his teams for the tremendous efforts in organizing this large event consisting of more than 200 participants and 10 countries with the aim to enhance health system resilience and population health. Special thanks to Mr. Fong and the Golden Jubilee Foundation and Ms. Shelley Lee for her dedications in various ways to support our schools. I promise our school will continue its mission to improve population health and well-being through education, research, and services locally, regionally, and globally. Thank you again to all of you for being here today, and hope you will find new partnerships and again new knowledge in the following sessions. Thank you very much.
Thank you, Professor Wong. Now it is our great privilege to invite Professor the Honorable Chung-mau, Secretary for Health, Hong Kong SAR, to deliver his opening remarks for today's event. Professor Low, please.
Professor Francis Chan, Professor Samuel Wong, Professor EKO, distinguished guests, ladies and gentlemen. I'm very glad to be here today to officiate this opening ceremony of the knowledge event and policy course organized by the Center for Health System and Public Research and Policy Address of the Chinese University of Hong Kong, as well as in collaboration with the Asia Pacific Network for Health System Strengthening. I wish, first of all, to extend a very warm welcome to all of the attendees here today, especially our experts and friends from the mainland and from overseas. Today's event, entitled Health System and Community Resilience, is timely for us to take stock of the experience from COVID-19 and to provide pointers for ramping up resilience in the public health systems in future. Academics and experts from the region gather here to share their COVID-19 journeys and insight on public health system resilience. My best compliment to Professor E.K. Yeo and his team at the Center for Health Systems and Policy Research of the Jockey Club School of Public Health and Primary Care, as well as the Asia Pacific Network for Health System Strengthening for organizing this very meaningful event. Public health systems are the bedrock to safeguard the life and limb of the general public. They are the bulwark against serious threats to public health, such as the onslaught of the COVID-19 pandemic. The COVID-19 pandemic was as much an ordeal as providing an opportunity for policymakers and public health experts to thresh out innovative approaches to tackle novel and emerging diseases, to reinforce our healthcare systems, and to weave closer collaboration networks with community stakeholders, as well as regional and international collaborators. To this end, enhancing resilience in preparedness, readiness, response, and recovery is the linchpin for effective actions and reactions in future. Collaboration between the government and the community has played and will continue to play an indispensable role to safeguard our public health. This calls for enhancing the resilience of not just the public healthcare system, but also each and every member of our community. While Hong Kong has successfully tackled multiple waves of COVID-19 pandemic and built up our resilience, we are committed to refining our tools and gearing up ourselves to prepare for the next pandemic, which no one here knows when will happen. With the support of our long-term community partner, with a 3 billion donation from the Hong Kong Jockey Club, the Hong Kong SAR government will enhance the local capacity in epidemic surveillance, early warning, prevention and control, and strengthening the joint disease prevention and control, as well as manpower training with the mainland authorities, and in promoting international cooperation in scientific research in various areas. The COVID-19 pandemic has demonstrated the critical importance of a strong primary healthcare infrastructure and workforce within the community. At the same time, it has also exacerbated the financial burden on our healthcare system and exposed the social costs of chronic diseases. A robust primary healthcare system will be an important line of defense against a wide range of potential public health crises. In this connection, the Hong Kong SAR government released the primary healthcare blueprint last year, which sets out the direction and strategies for coping with the challenges brought about by an aging population and the increasing prevalence of chronic diseases. We are pressing ahead with our work on various fronts, including the setting up of the district health centers in all of the 18 districts. By the way, the district council, the election will be on in 6 days' time. So I urge every one of you, the Hong Kong citizens, to come out and choose our district councillors and support the district health centers and in providing our primary health care. We also advocate the family doctor's law, enhancing the elderly healthcare voucher scheme, launching the chronic disease care pilot scheme, etc., with a view to providing comprehensive, sustainable, and people-centric primary healthcare services in the community. This will help us build a healthier Hong Kong that will be better prepared when the next emerging disease strikes. Today's knowledge event is a great opportunity for experts, academics, and key policymakers from the public health sector from different places in the Asian Pacific region to share their experience on how they collaborated with their community to prepare, respond, mitigate, and adapt in the face of one of the greatest public health threats in modern history. I wish the event a great success and everyone here a very rewarding 3-day program. Thank you very much.
Thank you, Professor Low. Next, let us invite Professor In-kyung-yo, Director of the Center for Health Systems and Policy Research, JC School of Public Health and Primary Care, CHK, to give a word of thanks. Professor Yo, please.
Professor the Honorable Chung-mau, Secretary for Health, Mr. Henry Vernon, Dr. Ronald, Professor Francis Cheng, Professor Samuel Wong, distinguished guests, ladies and gentlemen. It's a great privilege for me to give this vote of thanks. First to Professor the Honorable Chung-mau for really coming today. I know he's got a very busy schedule to officiate at this important event. And of course, also Dr. Ronald has agreed to give a keynote later, and we look forward to listening to him. Mr. Henry Fang, Chairman of the Hospital Authority, a very important member of the community that ensures that our health systems are resilient. And to obviously very important, the Golden Jubilee Charity Foundation, Ms. Shirley Lee and Mr. C.K. Fong, they're really staunch supporters of the school. They have been enabled us to run events like this and to bring colleagues from the mainland to take part in this event today. And of course, the Professor Laksono and the members of the Asian Network for Capacity Building and Health System Strengthening are very close partners in the region that we've been working together for over 10 years to develop policy programs for health system strengthening. Of course, we have a lot of keynote speakers and pleased speakers and country representatives that are very generously come today to thank them all for their contributions. And of course, ultimately also to Professor Francis Chan and Professor Samuel Wong for their very strong support to the work of the center. So thank you very much for your support.
Thank you, Professor Yo. Now, we would like to acknowledge the generous donation by the Golden Jubilee Charity Foundation in supporting the work of the Center for Health Systems and Policy Research, which includes today's event and the policy course held later in the week. Now, I would like to call upon Professors Francis Carlin Chan, Ms. Shelley Lee, and Mr. Chi Kin Thong to come on stage for a souvenir presentation ceremony. Professor Chan, Ms. Lee, and Mr. Fong, please. Thank you, Professor Chan, Ms. Lee, and Mr. Fong. Ladies and gentlemen, coming up, we have a very exciting line dance performance by Yun Fuk Tong. Let's get our cameras ready and welcome our line dancers. Now, our distinguished guests are performing an eye-dotting ceremony to officiate our line dance and wish for good health and luck.
Công ty kinh tế phục hồi bảo vệ và công hoạt động chế ngôi.
Please remain on stage, Professor Wong, Professor Chant, and Professor, Mr. Sorry, please remain on stage. Okay, we'd like to also call upon the following guests to come on stage for photo taking as well. Professor Samuel Wong, Dr. Ronald Lam, Professor E.K. Yo, Ms. Ada Chung, Professor Francis Chan, Professor Fan Wu, Mr. Edwin Cho, Ms. Shelley Lee, Mr. Chi Kim Fong, Professor Sirpan Supakankunti, Professor Ying Yao Chen, Professor Maria Herrera, Dr. Min Ji Ju, Professor Vivian Lin, and Dr. Suvir Low. Okay. Thank you, distinguished guests, and please return to your seats to enjoy the lion dance. I was explaining the performance. Now we're gonna have a group photo together with the lions. What a wonderful performance by the Winthrop Town. Another round of applause. Thank you. Ladies and gentlemen, that concludes our opening ceremony for the day. We'll be starting our keynote presentation in just a minute. Today, we're very excited to have Dr. Ronald Lam, JP, the Director of Health from the Department of Health of Hong Kong SAR, as our first keynote speaker. He will be speaking on the topic from health system to community resilience, combating COVID-19 pandemic in Hong Kong, China. Dr. Lam, please.
Professor EKO, distinguished guests, ladies and gentlemen. First of all, my profound gratitude to the organizer for inviting me to this significant occasion and share our insights on how we could tackle the challenges of the COVID-19 pandemic through building up health system as well as community resilience. Let's see if okay, right, thanks. So in my presentation, I will cover the Hong Kong's experience in tackling epidemics, how we build up the health system resilience from the lessons learned. And I will also cover the profound impact of COVID-19 to Hong Kong and discuss our response and preparedness measures. Finally, I will explore how we harness this experience to strengthen our capacity to combat communicable diseases as well as post-COVID challenges. So throughout human history, we have witnessed pandemics or epidemics of infectious diseases occurring time and again. Just the plague pandemic in the early years of the last century killed over 20,000 cases in Hong Kong with a fatality rate of 90%. And in the recent century, we also saw the emergence of SARS, the human swine influenza, and also the COVID-19. So after the SARS epidemic in 2003, we have set up the Center for Health Protection under the Department of Health and devised comprehensive preparedness and response plans. These plans clearly lay out the command structure and operation approaches during infectious disease epidemics. Our response mechanism is structured around 3 levels with different public health objectives: alert, serious, and emergency. And each level is activated based on comprehensive risk assessment. The importance of legal provisions in containment or mitigation of epidemics cannot be overstated. They are supported by the evolving legal epidemiology and public health law practice. After SARS, we have updated our legal framework for preventing or controlling diseases. We have enacted the revised Prevention and Control Disease Ordinance and its subsidiary legislations. It helps to align our preventive and control measures with the requirements of the WHO's international health regulations, with a goal to prevent local as well as cross-boundary spread of diseases. The biggest challenge ever experienced, the COVID-19 pandemic, arrived in year 2020. Since then, Hong Kong has experienced 5 waves, each of which was associated with clusters arising from imported cases as well as local outbreaks. The first 4 waves took place from 2020 to early 2021, and thereafter, we enjoyed a relatively prolonged period with 0 infection. However, the emergence of the highly contagious Omicron subvariant led to a very high surge in case, and which indeed caused uncontrolled local transmission, and that marks the 5th wave of pandemic. So the impact of COVID-19 on our health system has been very significant. We recorded over 3 million cases and more than 9,000 deaths. Particularly vulnerable are the elderly, and we are seeing 97% of the death cases or those among 60 years or above. The overall case fatality ratio for the elderly who aged over 80 years was as high as 10%. For the economy in the first half of 2020, our GDP recorded a decline of 9.4%, and our overall unemployment rate peaked at 7.2%. For the society, in order to break the local transmission chain, we implemented a wide variety of social distancing measures, unavoidably affecting the daily lives of our citizens. These include temporary closure of public facilities, restriction of dine-ins and the food premises, and so forth. And on education, schools were required to close for extended periods. The prolonged absence of school activities generated collateral harm, led to the rise in mental health problems, childhood obesity, and also respiratory viral outbreaks after the school resumption. So to facilitate sharing of how in the past 3 years we respond to the COVID pandemic through enhancing our healthcare system and community resilience, I would like to adopt a resilience framework, which is based on the scholars from different universities published in the Nature not long ago. And I revised that framework a bit, taking into account the experience of Hong Kong. So basically, the framework can comprise 5 pillars, namely governance and sustainability to deal with the COVID, our public health functions, the health services delivery, workforce and mobilization, as well as medical products. As for the overarching principles, it's self-explanatory, includes health for all, people-focused, and healthcare innovation. And underlying
Sorry. And the overarching principles below that are the foundation, which include community engagement, risk communication, cross-sectoral collaboration, robust legal framework, as well as science-based decision-making. As you are aware, during a pandemic, we are bound to encounter diverse views, as well as skepticism and queries. So to navigate these uncharted waters, there's no better approach than rely on scientific methods and evidence to guide us through. Coming to the governance and sustainability, as we know, the imported cases were detected at a very early stage in year 2020. We shortly activated the emergency response level and rapidly put in place the governance and command structure. A high-level steering committee comprising various departments chaired by the chief executive was formed, and we put in place a robust scientific advisory structure, the expertise and guidance of which have been vital in shaping our strategies. And as the pandemic lasted for as long as 3 years, building on the experiences gained in the first 2 years, what I call the containment phase, we refined the command structure to form specific task group solution teams headed by respective heads of bureaus during the mitigation phase. So this strategic shift had paved the way for a gradual return to normalcy. We have to emphasize that we are adopting an evidence-based approach for our anti-epidemic measures. We collaborated and commissioned academic institutions to conduct research so as to inform our policies on control measures and strategies. The research findings have been extremely useful in helping us to understand the virus vector, predict its spread and its mutation, and devise effective control strategies. The key public health measures would require a solid legal foundation for enforcement, and to ensure compliance of the community, we have enacted at least 10 new legislations during the pandemic. These legislations cover various aspects, including compulsory testing, quarantine measures, social distancing measures, and also the masking in the public places as well. So such a robust legal framework helps us to safeguard the overall resilience of the health system and also the community response to the pandemic. Financial support is a key element of sustainability, especially in the context of maintaining the essential services running in Hong Kong. And the government has established the Anti-Epidemic Fund, which is a critical component of our strategy to maintain financial sustainability and social stability, supporting those most affected, helping businesses stay afloat, and also laying the groundwork for the recovery. And to date, you may wish to know that we have launched a total of 6 rounds of measures, totaling to about 348 billion Hong Kong dollars. And infrastructure development is another key element of sustainability. In supporting quarantine, isolation, and treatment strategies, we have converted the recreational camps into quarantine centers, swiftly constructed purpose-built quarantine centers and community isolation facilities, such as the Penny Space Quarantine Center, just very near to the Disneyland, the Hong Kong Infection Control Center of North Atlantic Island, and what we call the Fun Towns. We also converted several public venues, including the Kai-Tak Cruise Terminal, sports centers into community treatment centers, or the step-down facilities dedicated for the elderly. In addition, we also enhanced our resilience through extensive community engagement. We engaged several hotels to provide quarantine venues for the inbound travelers, and also engaged contractors from the mainland to help us to boost up the construction capacity within a very short time. As such, the scale of operations for the quarantine isolation has been very immense. And here are some of the statistics. We have quarantined over 85,000 close contacts and also engaged around 70 hotels to provide such quarantine places. And over 840,000 persons have been quarantined in these vaccinated quarantine hotels. And for the community isolation facilities, we served over 240,000 COVID patients. Over 1.5 million close contacts have been subject to home quarantine or homework provided with the goodie bags as well. And the community isolation facilities have served over, as what I point out, over 200,000 COVID patients. So a study by the CUHK Professor Samuel Wong's team had conducted an international comparison of cumulative number of deaths from COVID-19 in the initial months. And in fact, we have performed fairly well with no number of cases. This has been attributed to a host of measures, including border control, social distancing, high volume testing, aggressive contact tracing, and so forth. And there are also a number of local studies also provide evidence that the non-pharmaceutical interventions have been effective in the containment phase. And on the left, you can see that the study describes the first and second waves of the COVID-19 pandemic, which pinpoints cases with their reporting day and the predicted reproduction number. And you can see that with various measures instituted, the reproduction number has been suppressed to as below 1. The right side describes the outbreak of a beta variant in Hong Kong, and our intensive measures of contact tracing, quarantine, and also genome sequencing, mass testing, etc., had helped to stop the local transmission of the SARS-CoV beta subvariant. Regarding public health functions, we have enhanced the COVID-19 surveillance with a multifaceted approach. We implemented a 11-tier surveillance system to enhance the disease and virus tracking, involving the professionals, institutions, and self-reporting by the citizens. And key to this approach is the development of a case portal and online reporting platforms, which facilitated prompt reporting and ensuring a timely response. And worth mentioning would be the sewage surveillance. Indeed, sewage surveillance has gained extensive attention and significant importance in recent years due to its potential to provide early detection and monitoring of infectious diseases and public health threats. And ultimately, during this pandemic, we have proved that sewage surveillance enable early detection, tracking of trends, and also the identification of hidden cases. It successfully tracked epidemic trends, provided early warning signals for the outbreaks. From our experience, the sewage surveillance can forecast the number of confirmed cases up to 4 days in advance, which enables us to institute proactive measures. As for the correlation with surveillance indicators, we found that a correlation coefficient of 0.97 between the sewage surveillance findings and the number of confirmed cases. So this is a very strong correlation. And the system also assisted us in detecting those hidden cases through the sewage network. So our experience showed that we can detect the virus in individual buildings as at least 2 days before the first case was identified. And in total, over 51,000 sewage samples have been collected in the high-risk areas during the 5th wave, and also more than 26,000 hidden cases have been identified. In the mitigation phase, the sewage surveillance also played a crucial role. It helped us to identify the presence and monitor the development of the variants and the genetic sequence, which provide early warning signals. So, for mass testing strategies, we also rely on 3 arms. First, the restriction testing declaration operations, which is about identify and test the individuals within specific restricted areas, buildings, or places at high risk of infection. And we also issue the compulsory testing notices and set up community testing stations in geographical areas which reported high number of cases. We officially recognize self-reporting RAT results as well since the March 2022. And there's a voluntary universal community testing program in the containment phase. we try to enhance the detection of residual cases in the community towards the tail end of the third wave. A total of about 1.77 million citizens came forward to be tested for the COVID-19 within 2 weeks. Our experience showed that at least 6 additional new clusters were identified through this universal testing program, which accounted for about 29% of local cases during that period. The implementation of this universal community testing program demonstrates the importance of widespread testing in controlling spread of the virus, and that time helping us to achieve the goal of dynamic zero. And to support such large-scale testing, we have to ramp up the overall laboratory capacity, both in the public and private sectors. We launched the External Quality Assurance Program for SARS-CoV for the private laboratories. And this program helps to ensure the quality and reliability of testing results. As such, we can engage these accredited private labs to do case confirmation. And during the 5th wave, we need to further scale up the testing capacity to ensure ample, high quality, speedy, accessible, and affordable community testing services are available and accessible in all districts of Hong Kong. With significant capacity enhancement, the turnaround time for PCR results has been greatly compressed to within 90 minutes at the border control points. And also a total of 85 PCR testing centers or mobile stations were in operation. About 70% of the population was able to reach a testing center within 15 minutes of walking. And the pandemic also sees the enhanced use of genetic testing and analysis. So during the containment phase, genetic testing was mainly used to establish the linkages between cases, which help us to identify outbreaks and carry out efficient contact tracing. As for the mitigation phase, we focus more on using the genetic testing for tracking the emergence and also spread of different COVID-19 variants. So understanding the genetic evolution helps us to monitor changes in virulence, transmissibility, potential resistance to vaccines or treatments. And we are proud that we are the first place in the world to upload the full genetic sequence of Omicron to the international database. To cope with the surge in number of outbreaks and or closer contacts, a total of 4 contact tracing offices involving law enforcement agency officers were also set up. The CTO was tasked with the critical work of identifying and tracing the contacts of confirmed cases. Indeed, our contact tracing strategies have evolved over time. You may remember that in the initial period, during the containment phase, we implemented a 2-tier contact tracing strategy. Not only we trace the close contacts of confirmed cases, but also the contacts of the close contacts. So this enabled us to ensure no leakage of secondary cases, helping us to prevent the further spread of the virus. And another study by the CUHK team, Martin, had reviewed the contact tracing, quarantine, isolation, and public health measures shown to be effective to controlling the spread of the virus. And as reflected, they are successful such measures to reduce the reproduction number to below 1. We capitalize on the healthcare innovation to enhance service delivery and resilience. Such innovation facilitates information dissemination and enhance access to services. Here are some examples on key innovations. We have the contact tracing tool, the real-time dashboard on COVID-19 thematic website to provide up-to-date information, the RAT self-reporting platform for citizens to report their status, and also the electronic health declaration for the inbound travelers. Other innovative systems included electronic wristbands used to monitor the compliance of people under the home isolation and quarantine, case portal for efficient and effective case management, and vaccination website for booking and digital vaccination records. Our quarantine and isolation strategies also evolved over the course of pandemic based on the prevailing epidemic situation, scientific understanding of the virus, and operational considerations. As the fifth wave arrived, facing the overwhelming cases, we quickly shifted from containment to a multi-tiered triage measure for isolation and quarantine. Those infected could report it through their online system, and such a strategic shift helped to contain the spread of the virus, protect the healthcare capacity, and preserve our healthcare system. And we have enhanced resilience through community support for those put under home isolation and quarantine. We have provided the government and NGO-operated hotlines. We mobilized community volunteers in distributing food and daily necessities, and also engaged the taxi trade to provide transportation services for the individuals to seek medical consultation in clinics or hospitals. So a total of 3.7 million anti-epidemic kits with essential supplies have been distributed to those under home isolation and quarantine. And another study published in Lancet examined these measures during the pandemic in Hong Kong. The findings showed that the stringent NPIs successfully controlled multiple epidemic waves caused by the ancestral strain of the virus. And these interventions, NPIs, include the social distancing, mask wearing, and so forth. So we also built up the resilience in health service delivery to manage the pandemic. And during the fifth wave, 2 public hospitals, the YEOH and also Donghua, were designated as COVID-19 hospitals, so that the non-COVID patients were transferred to other hospitals or private healthcare facilities and hospitals to ensure adequate resources were available. And designated clinics were established to provide dedicated care for the COVID-19 patients with mild symptoms so as to reduce the pressure on hospitals. And we engaged the private doctors in Hong Kong to provide free oral antivirals, ensuring continued care for the patients. The hospital authority also introduced the apps. While the apps booking, they could have enjoyed the telehealth services, and this expanded the range of remote care options. There is also the Chinese medicine telemedicine scheme, which provide remote care based on Chinese medicine approaches. Individual private hospitals and medical institutions also provided telehealth services as well. Ensuring a resilient supply, stockpiling, distribution, and urgent listing or registration of medical products were crucial. For supplies, thanks to the Central People's Government, we have procured large quantities of medical supplies, and we launched the local mask production subsidy scheme to ensure a stable supply of masks locally. For stockpiling, we have maintained an emergency stockpile of commodities, essential necessities, as well as the medical supplies, including PPEs, drugs, and vaccines. And regarding distribution, we need to meet the stringent requirements of cold chain storage and smart logistics, especially for the vaccines. Regarding listing and also registration of medical products, the use of COVID-19 vaccines has been authorized on an emergency basis under the newly passed subsidiary legislation. And the approval process for the use of antivirals for the treatment of COVID-19 has been expedited. So is the grant of listing approval for other medical devices, such as the RATs. A few words on the COVID-19 vaccines. When it became available in 2021, we aimed to secure the first 2 doses of 2 vaccines for the entire population. And due to uncertainties around the development and success of different vaccines, we adopted a dual track strategy, which was joining the WHO COVAX program and entering into advanced purchase agreement, APA, directly with the potential drug production companies. Fortunately, we have been successful in securing the vaccine supply through the APA, which was sufficient to meet the local demand. And as such, we donated the COVAX vaccines back to the COVAX facility to support other regions with insufficient supply. So this donation amounted to 7.5 million of COVID-19 vaccines. And in summary, over the past 2 years, a cumulative 20.9 million doses of vaccines have been administered, translating into a total vaccine coverage rate of over 93% for 2-dose uptake. And our vaccination priorities was first available and also targeted at the priority groups, but it's less than satisfactory. So we introduced a number of measures, and the most impressive one is the vaccine pass, which you can see from the graph. With introduction of the vaccine pass, the vaccine uptake rate surged. And another local study also demonstrated the effectiveness of various strategies implemented in Hong Kong to boost vaccination. The table on the right showed the acceleration of vaccination rate per week for different measures on improving accessibility and opposing restrictions. A high vaccination rates also played a pivotal role in fostering the strong resilience against the disease. Our studies here showed that 3 doses of mRNA or inactivated vaccine provided a very high levels of protection, above 95%, against severe or fatal outcomes. Mobilizing manpower resources have also been crucial in coping with the surge in demand for various health services, especially during the 5th wave, when so many healthcare workers were infected. So we recruited retired healthcare professionals, law enforcement officers, volunteers, medical students, nurses, also all support are enlisted during this the pandemic period. Especially thanks to the Central People's Government, they deployed teams of healthcare professionals to assist in the healthcare service. Community engagement is very important. We can see that during the pandemic, over 17,000 volunteers have been mobilized to prepare for over 3.5 million anti-epidemic service bags for distribution to all households in Hong Kong. The volunteers also assisted in implementing social distancing measures, community testing centers service as well, and also helping to disseminate the COVID-19 messages and encourage vaccination. So the dedication and support of community played a really significant role. And our risk communication strategies have extensively engaged community stakeholders to disseminate the anti-epidemic messages. By leveraging the reach and influence of these community stakeholders, risk communication efforts have been able to effectively drive home the message of prevention and promote necessary actions to control the spread. So looking forward, ladies and gentlemen, it is important to reflect on the lessons learned. First, we are honored to have commissioned Professor Yeo's team to have a comprehensive review, which he will share later, the findings and also the recommendations. And in this year's policy address, our chief executive of the government had unveiled new initiatives to boost Hong Kong's resilience and capacity to combat communicable diseases, covering mainly 3 major areas. First, enhance the surveillance systems for communicable diseases, improve data analytic capabilities, and develop more effective disease prediction models. Second, build a stronger epidemic response capacity, which involves developing integrated epidemic management system and also enhanced infection control infrastructure. And third, promote research on the prevention strategies and response measures for emerging infectious diseases as well. So turning back to the resilience framework, Hong Kong has endeavored to enhance resilience across multiple domains and at different levels, from individuals to business and the community as a whole. Our approach is inclusive, involving all stakeholders in the community. And this means not just government institutions and health authorities, but also businesses, non-profit organizations, and individual citizens. By working together, we hope we can create a resilient community that can better withstand, adapt to, and recover from the public health crisis. Our work is far from over. The post-COVID challenges, including antimicrobial resistance, mental health impacts, and the effect on NCD resources, behavioral risk factors also remind us that we must continue to adapt and innovate in our public health strategies. So, in gist, I would also like to take the opportunity to pay tribute to all the healthcare workers from DH and also all the organizations for their sacrifice in the prolonged war against this COVID-19. They are the unsung heroes protecting the lives of citizens. United, we prevail. And in ending, ladies and gentlemen, Nelson Mandela has said, "Do not judge me by my success, but judge me by how many times I fell down and rise again." We are certain that pandemics will strike again, but with professionalism, dedication, commitment, solidarity, and resilience, human will prevail. Thank you very much.
Thank you very much, Dr. Lam. Next up, let us invite Professor E.K. Yeo, the Director of the Center for Health Systems and Policy Research, JC School of Public Health and Primary Care, to deliver our first morning plenary session. His topic is on preparedness, readiness, responses, and recovery on health systems in the COVID-19 pandemic, enhanced whole of society approach to public health threats. Professor Yeo, please.
Thank you very much, Dr. Ronald, for that really excellent overview of all the work that's been done over the 3 years. As Dr. Lam says, I think what I'm proposed to do in the next half an hour is talk about our view in terms of how a system for early detection, assessments, and response to public health threats in the 4-phase enhancement for resilience. This work, as Dr. Lam mentioned, is commissioned by the Health and Medical Research Fund for novel coronary diseases. This one was set up early in the pandemic when we first had our first cases, and the government invited the tertiary institutions to provide the proposals for research. I think we were the only school or university only submitted research on policy. So we had 3 studies. One, in 2020, when the pandemic first started, we embarked to look at investigation of Hong Kong's early detection, assessments, and response, the so-called CEDA system, for new emerging infectious disease outbreaks of the COVID-19. And subsequently, because of the protracted pandemic, the government asked us to extend our study so that we could look at our system to new emerging infectious outbreak in the light of the lessons learned. And there was a second study, which I'm not going to talk about today, on epidemic intelligence and a data-informed risk assessment system to inform policy decisions, which is critical for maintaining the control to enhance recovery. I'm going to talk about the methodology, the findings, the challenge and lessons learned, and enhance resilience, and then to end up by talking about systems and community resilience. As Dr. Lam showed you, this is the period that we had, the 5 waves that we had, in the 5th wave, when the whole system was overwhelmed. So the sole objective was to develop a system of early detection, assessment, response based on the lessons learned in the trajectory of the different waves of the COVID pandemic. It was based on the review of the literature and overseas experiences to gain insights for a system to calibrate public health and social measures and health system and community resilience. We also, in second stage, also want to include readiness as part of the study, which is quite a new concept in the preparedness, and community resilience for enhanced system based on the lessons learned. This, in fact, is a 3-year study. It's a multi-stage mixed method design of literature and policy review. We had a number of expert workshops, both local and international, to synthesize the findings from the preliminary framework. We had 2 comparative case studies in 2 phases. In the early stage, we had the comparative study with Singapore, Japan, Malaysia, South Korea, and in Shanghai, where we looked at the impact of non-pharmaceutical interventions on transmission and severity during the first 5 months in the Western Pacific region. We also had a second comparative study, and our colleagues from Australia and Singapore will present later, where we actually went to the Melbourne and New South Wales, Singapore, to really compare the approaches in the later parts of the pandemic. We did 2 informal interviews of policymakers, administrators, business sector, institutions, social and support services, health professionals, patient groups. So it was quite an extensive study that we did. And we focus groups of healthcare sectors, the doctors, nurses, pharmacists, vulnerable community groups. We did focus groups of residents in subdivided units. For our overseas colleagues, you may not be aware that in Hong Kong, because of the shortage of housing, we have about 300,000 people living in these 12 subdivided units. So they are flats which are divided into little cubicles, where it's almost impossible to do any infection prevention control. We also did focus groups of ethnic minorities, older people that live alone and immunocompromised. Based on all these things, we developed the Delphi statements and had 2 group Delphi meetings of 10 local experts. These were really key people, very senior decision-making positions, and people in past leadership roles from both the public and private sector. So we had the Delphi in the early stage of the pandemic, and then updated it in the later stage, and had consensus statements on clarity, importance, and feasibility of the improvements for local adaptation. In total, there were 98 Delphi statements. So this is what we envisage would be how systems can be more resilient. So it's a force-phase enhanced whole of society system, where we start with the preparedness, and the second stage the readiness, the third is the response, and fourth is recovery. And of course, this is also looking at the stages of the transmission. As we know, we had no cases, sporadic clusters, and then community transmission. Of course, with each of these components, there are Delphi statements that cover the different areas, which I'll mention later. And then because of all these aspects, this is how preparedness, the resilience of the system can be maintained. So it starts with the preparedness stage, having good readiness, an effective response, and then recovery, going back, feeding back to the preparedness system. So health system resilience is the ability of a system, community, society exposed to a hazard to resist, absorb, accommodate, adapt to, transform, and recover. So it's a whole cycle. It's not just the ability to withstand the forces. Through the preservation and restoration of essential basic structures and functions through risk management. So these are the Delphi statements, and I won't go into details, but in the preparedness stage, we looked at 5 domains: surveillance and risk assessment, the command structure, legislation, drills and exercise, search capacity and contingency. So it provides the general structures and actions and processes needed to tackle public health emergencies in the whole of government and whole of society approach. Readiness is something, a very new concept, where there are 16 statements in governance and leadership, integrate surveillance and early warning systems, the emphasis on early warning systems, which Dr. Lam also talked about, risk and risk severity assessment, response plan adaptation, search capacity, competency assessments and enhancements, risk communication and community engagement. Readiness is defined as an intermediate state to ensure the timely operational development of the capacity and capability for response. So WHO talks about preparedness and readiness as being an evolution stage, where preparedness talks about a general structure to an unrecognized or generic threat, whereas readiness is the capacity, looking at the capacity and capability for the response when you're alerted to a possible threat. So in the readiness stage, you probably activate and adapt the preparedness plans to tackle the specified threat and delay preparedness to the rapid response. In response, there are the 32 statements on case finding, contact tracing, case management, isolation, social and physical distancing measures and community quarantine, port health and international movement control, risk communication, public engagement, and importantly, infodemic management, social and economic mitigation. So it's implementation of strategies at government, healthcare, and community levels. And of course, recovery is important because it's when we have normalized ourselves, backlog, review, and build back better. So it's clearance of the backlogs, and then to roll back better for a resilient system. So I'll talk about the challenges and the lessons learned, and then the enhancements for the early detection system. Dr. Numbers will mention some of the gaps in surveillance systems early on. The data sources and systems for early detection were problematic, and also risk assessment and rapid response for pandemic control. Importantly, operational readiness is not explicitly considered in the preparedness and response plans, because it's really the key to resilience, because it's the early detection, your alert of what something's going to happen, where you adapt your systems. Command structure had to be ours, which for decision-making coordination, which Dr. Ems talked about. Capacities and facilities for public health and social measures were overwhelmed. Engagement of the private sector, health sector, and NGOs were perceived as ad hoc in the very early days. In our interviews and focus groups, the private sector mentioned that the government was really quite reactionary in contacting them. It's only when they wanted them to do something that they were involved. They were not engaged early in the preparedness stage. This communication and community engagement was perceived as inadequate early on, and there were implementation issues in social and economic mitigation. So the lessons learned, the government very quickly looked at how they could improve the new command and coordinate structure. There were legal amendments for the public health and social measures talked about, building of very rapid building of facilities, scale up testing, and PPPs. Developing portable data to efficiency of case finding, contact tracing, and quarantine. And I think Dr. Lam mentioned about contingency. So I'll talk a bit about that in terms of contingency when surge capacity is exceeded. Because in most of our preparedness plans, we only talk about surge capacity. But with surge capacity, can we deal in terms of some incremental increases? But when the systems are overwhelmed, you cannot do more of the same. You really need to look at what contingencies are needed when in that sort of situation. And then later on, of course, government now has these care teams and the district health system to coordinate community support. So obviously, these are not all the lessons learned, but I thought these were the key ones that I want to share with you. So based on our studies and the Delphi statements, we are recommending augmentation of our systems. Now, I mentioned some of these. I won't talk about the details. Obviously, the first one, very important, is the augmentation of the surveillance system. It has got to be One Health guided. So the interaction between environment, animal, and human health is important. We need to have different data modernization platforms, expanding data sources. We need to capture information with social media. It must be real time. Our platforms must be linked up. And then obviously protection of data privacy, which our commission will talk about later in the afternoon. And importantly, obviously, in terms of the data sources, we need to look at not just so-called not just database, but event-based and community surveillance. And of course, surveillance of animals. And of course, during the pandemic, we had infections in the hamsters. And obviously, the legislation and the surveillance systems in future must cover these as well. So it's the whole infrastructure of the surveillance transformation which the government is looking at. The other elements, of course, not just the surveillance, but the surveillance agent. So this is the Center for Health Protection. I mean, they're revamping our systems where we thought that's important in terms of the data sources, not just from the usual epidemiological stages, but also from behavioral sciences and from social sciences to really have multidisciplinary expertise in risk assessment. We think that there should be a behavioral insights and intelligence unit that can do the analytics. So it's not just what comes in, but how you deal with it to predict, to make predictions, and then to assess the effectiveness. I think certainly there's in-house research and data capacity, but to build that capacity for data analytics, to look at surveillance criteria, indications of early detection. So you need a system in terms of where you have early signs, but with a lot of these early signs, you need to assess the risks and of these, do the analysis of this the early signs, because not all of them are reliable. You look at transmission scenarios and risk profiles of community settings. So obviously there's common data infrastructure working with the academic institutions where we can really enhance the capacity of the government to build up this new surveillance systems. The command structure which the government adopted is a 3-tier one. At the command level, where there are 2 levels of alert, serious, and emergency. At the organization level, the intergovernment collaboration. And then what's important between the non-governments looking at the relationships between government and non-government. And of course, the operational level with the health, non-health sector, and then the other sectors, and working with civil society, the private sector, and the expert communities. So coordination is quite important. I think this happened during the pandemic, when government recognized the importance of working with the business community and the welfare sector. So in the future, we thought that in the preparedness stage, all of these things should be institutionalized. So to delineate the roles of government and not government sections. So it's important during the preparedness stage and not during the response stage for government to really look at the mobilization of the plans, the coordination of risk communication and community engagement, collaborate with mainland regional authorities. Government also increase coordination with the private sector and civil society. Of course, in the early stage, to agree of the roles and responsibilities, surveillance and pandemic controls with the private healthcare sector, having service agreements in the preparedness stage for response capacity, which can be activated and adapted in the response stage. And for the civil society to identify the supporting roles for the public health and social measures, from networks for reaching vulnerable groups, and then to promote the community's participation. So early engagement in the private sector is important to get familiarity with the emerging measures, to develop the capabilities and competencies, identify areas for improvements, and of course then the drills are important to involve the private sector in drills, which can be team-based exercise from tabletop functional to full-scale exercises, and then to consider engaging international experts as observers for an audit. So it's a key step to engage the private sector for vulnerable populations. Of course, for when there's contingency, you need to expand the public health capacity and capabilities. So I think this was something that was very obvious because the shortage of public health expertise. So one of the recommendations that people have been looking at is really to include public health training programs in many of our health professionals so that they have at least a basic training and they can be called upon to help during a pandemic. To have service agreements to private hospitals for case management and treatment, accreditation costs and quality assurance of public health knowledge interventions, and to coordinate the primary care doctors, community pharmacists, and allied health professions, and then the allied professions to play complementary roles in the rehabilitation and support. So this is quite an important element when contingency plans, when capacity exceeded, when the search capacity exceeded, right? So we need to review the control goals and strategies. We need to look at the options for isolation and quarantine, which Dr. Lam has talked about. Civil mobilization to share the public health and social measures. And then for the other officers to share in surveillance tasks. And the care team to provide social needs of communities. So we need to revise the case management, redefine the essential health services, options to free up healthcare capacities, review severity indicators for patient admission, discharge transfer, which Dr. Lam has covered, health professionals working in primary care, specialty and subspecialty areas to be involved in case management infection control, and to update the list of doctors who are competent for patient ventilation. This was in the hospital authority. And then obviously enhance contact tracing isolated quarantine capacities. The government engaged different departments. They utilize CCTV Octopus card data, the automation system to engage mobile phone networks, credit cards to trace routes and locations with the support of the legal department and the privacy commission, and to engage the private sector in case detection, sentinel system reporting with clear protocols. Because we need to prioritize support for vulnerable groups, home care services, and financial support. Because we need to define and identify the specific vulnerable groups early, collaborate with NGOs, community groups, and social networks, strengthen support on social sector, the infection prevention control to personnel working in the sectors, support of the personal protective equipment for the staff and for mental health. Because the district health centers are now in operations, and the care teams provide community outreach service to support medical, social, home health, food delivery to vulnerable populations. And then the government also should review the implementation of the subsidies and the effectiveness. One key element which is important in terms of pandemic control is the role of the community in control. Of course, it's quite important because of a lot of misinformation during the period to look at risk communication and community engagement strategy. In the readiness stage, we should already identify the spokesperson for internal communications, define the roles of experts, design two-way communication strategies with community leaders, stakeholders, identify the channels of communication, and delineate infodemic management. So then on the other side, you need to have social listening to collect community beliefs, behaviors, perceptions, questions, concerns, knowledge gaps, and suggestions, engage and train communities, NGOs, religious patient groups for information delivery. Because if you have prepared these, then obviously in the response stage, you can activate the task groups and adapt the plans, and with public sentiment analysis, promote participation from multidisciplinary stakeholders and collect feedback, manage infodemic with evidence-based analysis and support from professionals. You need to adopt different strategies and at different levels, during the alert level because of rapid risk perception analysis, at the emergency level to define barriers of compliance behavior. So we move on to the final stage of recovery, where we need to look at how do we increase our workforce supply and retention. We need to now look at how we are able to incentivize and clear the backlogs, but looking at the waiting lists, splitting outsourcing of services. So this has already been done. And the community care system to invest in primary and community care, which the Secretary talked about, expanding whole care, digital infrastructures, and upgrading health infrastructure. So for the health system from lessons learned, we need to assess and identify the gaps, identify lessons learned, develop short, medium, and long-term recommendations, and invest financial resources. So this is the element of readiness which I want to share with you. WHO differentiate the preparedness and the readiness phase. Readiness is defined as the intermediate state between preparedness and response, and to ensure timely operational development of the capacity and capability for the response. It enables to promptly activate and adapt the preparedness plans, because preparedness plans tend to be more generic, but you need to adapt it for the specific threat. Linking preparedness to rapid response. So we have identified 7 domains of readiness: the governance, leadership, risk and severity assessment, response plan adaptation, look at search capacity and community engagement, and then the integrated surveillance and early warning systems with 4 attributes, which is review and adaptation, timeliness and responsiveness, resource prioritization, coordination, and engagement. So the conceptualization of readiness is state, because when we looked at the pandemic, really we're not just talking about the readiness between the preparedness and the response. We're looking at the readiness in the changes of the state. So we think conceptualize readiness would be better served infectious disease as a state, where the outbreak and as a state for hazards and the changing and unanticipated host, agent, and environmental dynamics. So the various systems would in the future would not just pick up early detection of the threat, but also the changes, dynamic change in the threat, so they can prepare better for the next wave, as it were. So operational readiness will facilitate health system resilience, because when you have an undefined prepared stage, that you in the ready stage, you identify it, you then adapt your preparedness space, then you enable you to absorb the threat and then to transform in the response stage. So a generalized and undefined preparedness plan is adapted and modified to a defined readiness plan for the local context in the threat. So it enables you to calibrate response controls to absorb the threat and enables you to review and transform the system. So finally, I just want to talk about the health system and community resilience. Right, I talked about this already. So these are the other element of another way of looking at health system resilience. You have got the governance and financing, the workforce, medical products, public health functions and delivery. And then in the middle would be community engagement and collaboration across sectors. So these are the various elements of the four resilience elements of highly effective country responses. This is based on the paper that not the latest paper, but the original paper that Lai-ling produced in Nature Medicine, where they look at the different components of activating community responsiveness, how the health system capacity can be adapted, how you preserve health system function resources, and then to reduce vulnerability. And finally, about community resilience, it's the ability of communities and groups to adapt and thrive in response to external stressors. So based on review, there are 5 capacities: mitigation to minimize damage to casualties, absorbing the shock, recovering, adapting the shock, transformation. So the same elements. And these important in terms of the level of social capital, economic development, community infrastructure, the available of communication, information management channels, and the community preparedness and company members' well-being. And this review paper looked at the different elements of community resilience, and they talked about institutional resilience, social resilience, economic resilience, built environment and infrastructure resilience, health and demographic resilience. So I think I'll end here by just giving you this very brief report on the work we've done, where we looked at how the system can be improved to enable resilience. Thank you very much.
Thank you, Professor Yeo. After 2 very engaging sessions, it is time for a short break before we move on to our second plenary session. There are drinks and snacks available in the foyer. Please enjoy. A gentle reminder that there's no food or drinks in the auditorium here. If you're looking for a washroom, they're on this floor as well as on the floor of the foyer. If you need assistance, please feel free to talk to our staff. We'll be reconvening here at 11. Thank you.
Wow, 我個超唔知做乜。
幫佢 delete 返。
OK，知道，唔該晒。Oh no，佢係咩嚟㗎？呢個唔係佢話要 show 個 time 㗎嘛？呢個呢個係咪？試下。唔係喎，咁嘅點解？係，呢度有個芒㗎。有個芒。你試下放我個蛋，揾唔揾到啊？因為我要改啊。你係邊度嚟？最後嗰個。係，唔該。
Ong Wen Lin, Executive Associate Dean, Lee Ka-shing Faculty of Medicine in the University of Hong Kong, to moderate this session for us. Let's give a big hand to Professor Lin.
Welcome back to the session. We had, I think, a great overview of the Hong Kong situation and the lessons for Hong Kong. I think for those of us who've been involved, it's still easy to forget the details. And so that just goes to show how everybody else in the community are likely to forget. And all of the reason why we need to really learn the lessons as we move forward. So I think this morning we move into what we might call the new normal, which is that people will be on Zoom. We lose the opportunity of being able to interface with people informally, but we will be able to at least hear their own in-depth experiences. So to get us started, we will go to New South Wales in Australia. Now, I think we have quite interesting contrasting jurisdictions we will be hearing from this morning. And one of the very distinctive things about Australia is that it is pluralist in structure. And therefore, there are some very distinct challenges. But when we talk about the Asian exceptionalism in the COVID, we also include Australia and New Zealand in the way that they have responded so very well, and with many lessons, I think, that are really worth sharing across so many countries in the region and beyond. So let me introduce, we have three of the key people from New South Wales who are with us this morning, and COVID response is very much a collective effort, and we're very happy to have the collective leadership from New South Wales. Dr. Kerry Chant is the Chief Health Officer and Deputy Secretary for Population and Public Health in New South Wales Health. She's had over 30 years of experience in various senior positions in New South Wales, and was the person who the community saw on a daily basis in the media. And working with her closely are Dr. Jeremy McAnulty and Dr. Christine Selvey. Dr. Jeremy McAnulty is a public health physician and is the Executive Director of Health Protection New South Wales, who also has been a key person in New South Wales Health in the public health side of things for decades. And Christine Selvey was, in an earlier part of her career, the head of communicable diseases in Queensland, and has been in New South Wales Health as the director for the communicable diseases branch, and again, one of the key leaders in the COVID response. So I hope all this technology works. And so without further ado, let me invite the New South Wales team to share their experiences with us.
Excellent. Thank you. Thank you very much for the invitation to present. I would like to, before we commence, acknowledge the traditional custodians of the land on which I'm presenting from today, and for us it's the Gammarangul people of the Eora Nation, and pay my respects to elders past, present. I'm also joined with my colleagues who have also endured the experience of the pandemic alongside me. Next slide. Prior to the pandemic, we had planned for and responded to a range of infectious diseases and environmental threats in New South Wales, including the H1N1 2009 influenza pandemic, Ebola threats, bushfires, and large mass gatherings. And it was important that we sought to build in the lessons from these responses to strengthen business as usual capabilities, in addition to incorporating new learnings into our planning for future threats. I think in reflecting, having strong foundations in business as usual capabilities is essential for that resilience to the enormous challenges posed by a pandemic. New South Wales Health had an established operating model underpinned by long-term investment in data analytics and connectivity. It had operational structures designed to respond to and deploy resources across the health system. And there was also sustained investment in local public health expertise with strong local relationships. Our local health district structures, which are basically the state is carved up into about 12 geographical regions, and we have local health districts. Health services are responsible for providing health services within those regional structures, and then embedded in those we have public health units which are focused on disease control and prevention. The strength of that model is that there is strong local response and engagement with local communities, and that is, I think, a key factor in success. Having a single New South Wales health pathology service also allowed us to rapidly develop testing capabilities and enabled access across the state to testing. We also worked with our private pathology laboratories very closely as we scaled testing throughout the duration of the pandemic. We also have well-established existing relationships with our primary care and clinical groups, our educational facilities, our aged care and disability service providers, and as I mentioned, our private pathology providers. And these relationships and practice in working in a business as usual system really were able to be leveraged in the context of the pandemic response. The New South Wales health system had also made some significant steps towards being digitally enabled, and this presented many opportunities to support high-quality data, innovative models of care, and different approaches to contact tracing and linkage to care. Next slide. This slide demonstrates the COVID-19 pandemic timeline. And the slide shows that reported COVID case counts in 2021 and 2022. So 2020 was characterised by the initial wave and 3 smaller outbreaks, and 2021 was characterised by a number of incursions, and the second half of the year, a wave associated with the Delta variant, commencing around that June-July period. And then later in the year, we saw the emergence of the Omicron variant. The Delta wave was suppressed through intensive public health measures, including the rapid rollout of vaccination, with over 16-year-old vaccine coverage, double dose, around 92% by November. In November 2021, the Omicron variant was introduced, and this variant and its subvariants drove 4 distinct waves from December 2021 to early 2023. The first wave in 2022 was driven by BA1, the second BA2, the third a BA4-5, and the fourth wave by a more diverse array of subvariants as the virus continues to evolve and evade the population's immunity derived from infection and vaccination. It should be noted that you cannot conclude the level of community transmission by looking at notifications alone without considering the context of the waves. Important factors include testing behaviour and availability and access to testing, and reporting behaviour for our rapid antigen tests at the time of the recorded waves. Put simply, case ascertainment has changed across the waves, and today we would only be ascertaining and hence reflecting in notification data a small proportion of COVID cases in the community. Therefore, we need to use more diverse range of data to understand the level of community transmission so we can keep our community informed. We have found health staff furloughing data, the number of antivirals prescribed, the number of aged care outbreaks are particularly useful and are currently evaluating a range of other indicators, including sewage surveillance, which we are also finding is a useful, although a little bit lagged, indicator of community transmission. We have also seen a disconnect between the level of community transmission and the impact on health services due to the level of immunity in the population and access to effective antivirals for those at risk of severe disease. COVID continues to impact the community, and we need to continue to support the adoption of proportionate public health measures such as vaccination and easy access to antivirals for those eligible, reinforcing messages such as stay at home if you're sick, mask wearing, and promoting the use of well-ventilated settings for social activities, particularly if participants are at risk of severe disease. When community transmission is high, it also presents challenges for preventing outbreaks in settings such as aged care and hospitals. At this time in our pandemic response, it's important that our measures are proportionate, balancing risks and benefits associated with our public health advice. The pandemic has impacted on almost every facet of our lives, and from a health perspective, to assess how we have performed and to identify what we need to focus on now to optimise the health of our community, we need to monitor a broad range of measures. Now, these are some of the health-related measures, but I'd also like to note that we would also consider it important in our whole government approach to look at measures that are also lie outside health directly. But some of our measures that we have looked at closely are all-cause excess mortality, COVID-related deaths, life expectancy, how we've managed with our treatment and preventative services and how we maintain screening and immunisation programs, access to mental health services, overall mental health status indicators for our population, and social and emotional health and community wellbeing generally. I now want to reflect a little bit on excess mortality. The concept of excess mortality refers to an increase in all-cause mortality above what would be expected in a given time period. Across the world, health and statistical authorities have used excess mortality as a measure to assess a country's performance in managing COVID, as well as to allow a comparison between countries. And why use this measure, we may ask? Firstly, this measure accounts for deaths due to COVID, but also accounts for deaths indirectly related to the pandemic, such as reduced access to healthcare more broadly. Secondly, excess mortality can also account for misclassified or undiagnosed COVID-19 cases. Now let's look at the graph. Here we see all-cause mortality follows a seasonal pattern, with more deaths occurring in the winter months generally, peaking in July. In this model, the baseline period is used between 2013 and 2019, as we are asking the question, what would we have been expected to observe in the absence of the pandemic? The blue line indicates the modelled seasonal baseline of expected deaths, and the light blue area reflects the usual variation. And the yellow line reflects the actual recorded all-cause mortality. So in 2020, all-cause mortality was below the forecast mortality for many months of the year, and this reflected the impacts of the public health measures during this period. For example, the public health measures were significantly reduced the impact of respiratory infections, and influenza activity was negligible during this period. For much of 2021, all-cause mortality was generally within the expected range. In 2022, corresponding to Omicron and an early influenza season, we saw an increase in excess mortality estimated by the ABS to be around 10.7% and 8.6% for the first quarter 2023. Next slide. Resilience to infectious diseases and other natural disasters can be impacted by many factors. the underlying health of the population, such as pre-existing burden of chronic disease and risk factors, social determinants of health, for example, household size, insecure employment, access to affordable high-quality primary care and specialist care. In respect to COVID-19, we also saw outcomes and impacts vary significantly by socioeconomic grouping. Strengthening the focus on public health, including prevention, access to high-quality primary care, and addressing the social determinants of health will address the significant existing differences in health outcomes across our population and also increase the resilience to new infectious disease threats and natural disasters. I now want to take the time to just reflect on some of the lessons learned from the pandemic. Public health actions should be informed by data and evidence, enabled by technology, and have a strong focus on equity. New effective technologies should be rolled out rapidly and equitably. Some of those technologies include vaccination, rapid antigen tests, e-pharmacy scripts, and access to virtual health services. It's important that processes of formalised and enduring emerging structures are essential, including clear, inclusive, and widely understood governance and decision-making processes. What is key is engaging community and multidisciplinary perspectives early and regularly through the decision-making process. Public communications need to be co-designed, easy to understand, and available in many formats, including through videos and social media. And it is also incredibly critical to partner effectively across communities, recognising the importance of implementing local public health solutions with governments, academic partners, health service and business organisations. In terms of technology, the pandemic demonstrated the utility of disease modelling and advanced genomics such as whole genome strategy and sewage surveillance. These tools have now been adopted as part of our routine practice. Highly accurate PCR testing was developed rapidly and deployed at scale with rapid feedback of results to individuals and even contact tracing self-initiated. Rapid antigen testing also provided incredibly useful, and the community was surprisingly willing to adopt at-home testing, and I think this has resonance with our approach to other communicable diseases and for future pandemics. The rapid worldwide collaboration occurred to develop an effective vaccine, and this surpassed our initial expectations. And rapid vaccine rollout will likely be a cornerstone of our future responses to emerging and re-emerging threats. Also, as countries have developed vaccine technology and vaccine manufacturing capabilities within their national bounds. The COVID response saw the rapid incorporation of different approaches to health service delivery, such as online healthcare remote monitoring, prescribing, as well as workforce surge models, which really utilise the full scope of practice of a number of health professionals. We need to continue to support the digitally enabled models of care that delivered the outcomes for patients. Public communications is a key and cornerstone of our pandemic response, and the pandemic highlighted the need for timely, clear and open communication to build community trust and cooperation with public health measures. In this area, we have learned a lot. Messaging needs to be evidence-based, informed by customer insights and delivered by trusted experts. Multi-channel content was essential to ensure reach. Websites, social media, text messages, media including radio and TV, electronic direct mail, search engine optimization, stakeholder packs and posters, a comprehensive response. We engaged across government agencies and with external stakeholders, including industry groups, community leaders, Aboriginal and multicultural organisations, to leverage off existing communication channels and to improve the reach to reduce misinformation. New South Wales Health and New South Wales overall has a significant cultural diversity and a large First Nations population, necessitating specific and enhanced focus and engagement. Examples included multicultural media online, media conferences targeted to particular culturally and linguistically diverse communities, paid media partnerships with community channels, simultaneous translation of press conferences undertaken through a partnership with SBS, and a raft of collaborations with amazing community leaders and community groups. I hope my presentation has already touched on the important component of partnering effectively with the community. Partnering with community is essential, and this has to happen at a state and local levels. And one example was the work with the Pacifica community. If we go back a slide, New South Wales Health worked with the Peak Pacifica community groups to support dissemination of consistent messages. This enabled identification of needs. Resources were developed by communities supported by New South Wales Health, and the COVID Hope Toolkit, Hope Options for Emergencies, was developed. Doctors identified by the community are important in message dissemination as they are trusted. We also have worked to embed this way of working with communities in this co-design as part of our core business as usual approach to communicable diseases more broadly. It's also important that we partner effectively across government. This slide just shows how all of government actually worked together to support vaccination, to support testing centres, and through our educational facilities. Next slide. So in summary, it's important to be prepared for future pandemics, that we actually have a base health system resilience. We need to focus on equitable access and delivery of health care. We need to focus on equitable primary health care, general practice and pharmacy. We need to strengthen the response for all public health emergencies and natural disasters. We need to maintain capacity and capability through continued investment in trained health workforce, integrated data analytics, and leveraging new technologies and models of health service delivery, which will enhance our health system's resilience. And importantly, we need to tackle any underlying inequities in terms of our population, including the social determinants of health. Tackling those will mean that we will be more resilient going into new pandemic or meeting any future health threats. Thank you.
Thank you very much for that overview. While we've got them online and fresh in your mind, can I invite any questions? While you're thinking about it, you know, I know New South Wales and Australia, and you know, Australia is a bit like one country, two systems. It's federal, and indeed, very large geography, quite widespread, and you've also made mention of a very localized infrastructure as well as capacity that's been in place with the public health units for a long time. Can you talk a little bit about the strengths and weaknesses of this sort of decentralized structure and some of the challenges of coordinating across different levels of government? Kerry, I think New South Wales, you're on mute. Not sure whether you heard my question.
Yeah, it's short, easy.
No, it's just external. Can you just type it so we can't?
Okay, I can hear this.
Yeah.
The voice, that's okay, yeah.
They can hear. Sorry, can you repeat the question? We missed it, sorry.
Yeah, just a quick question. Interested in how you managed to coordinate across both.
Would you type the question, please, in the chat? We just can't hear you at the moment because you're on mute.
Okay, so let's try this.
What else?
Can you hear me now? I think okay. You've got a decentralized network, which of course has a strength in terms of knowing the local areas. You also have a challenge of two different levels of government, with the federal government, of course, having its own policies and responsibilities. Can you talk a little bit about just the challenges of coordinating across these different levels?
In Australia, whilst we have a range of states and territories, and we have a Commonwealth government, we are used to working very closely in tackling communicable disease threats. So we have existing structures such as the Australian Health Protection Principal Committee, we have Communicable Disease Network Australia, we have networks of our laboratories. And so tackling communicable disease threats as a nation, working with states and territories, is probably being built into the structure, and we've done it previously in the previous pandemic. Obviously, each of the states and territories have different challenges. Some of them are more less densely populated. Some have very high Indigenous populations. But overall, we saw significant cooperation and coordination across states and territories with the Commonwealth.
Thank you. And I think that goes to the issue of the structure that you've actually spoken about. That's so important.
And one of the things that probably to draw your attention is the Commonwealth Government has announced that they will be creating an Australian Centres for Disease Control, and that will provide an opportunity for us to further strengthen data sharing and surveillance and the way we coordinate activities to tackle communicable disease threats.
Right. I think about that in singular as well as one of the responses of how we move forward. But let's now go to another extremely decentralized place, Indonesia, with its 17,000 islands, and an extraordinary effort. To talk to us, we have Dr. Siti Nadia Tarmizi, who is the head of communications and public service in the Ministry of Health. And she was also the spokesperson for the ministry during COVID-19, and more recently, the spokesperson during G20. And that's, of course, been very important as an international effort. And she had previously also been the director of communicable disease. She is a medical doctor as well as holding a degree in epidemiology. So let me turn it over to Nadia.
Okay, thank you, Prof. Vivian, and good morning, everybody. So I would like to share the Indonesian, especially experience during COVID-19, I think. Okay. Okay, can you see my slides?
Yes.
Okay, I will start the presentation. So, so what we learned from the COVID-19 is first, the goals of COVID-19 is we are aiming to stop transmission, reducing number of new cases and no more death cases. And then especially we know that because this is the new disease, providing health services for the patient. And of course, we know because of the policy, for example, like lockdown or limited of the activities among the community, we need to minimize the impact of the COVID-19 in the social services, economic, and other sectors, including education. So what first we have to know about our Indonesia situation. Dealing with the new diseases, we really need to find what will be the best solution in tackling the challenge. We have 280 million population, and then we have like 17,000 island. And then, of course, the other thing is the mobile penetration is like 100%, and then we have like 500 for 549 cities, and then we have more than 1,000 more than 150 language, local language and indigenous population. Of course, the main challenge is how to provide accessibility, affordable healthcare, accurate and up-to-date healthcare information. And sometimes because of the COVID-19 and new diseases, sometimes it's really need to keep update, and there is like a challenging in the implementation of program with the very various population and very quite numbers of area. And then the socialization, like I mentioned, because we have like 130 local language and indigenous. And Indonesia is up to now, from the last data, 13 November 2023, that we are reported like 6.8 million cases, and then we have like 161 death cases, and we report like 448 million vaccine doses have been administered. As you can see here, this is Alpha wave, and then Delta wave, and then we have like Omicron variants here, and now we find a very small number of cases, and this is the death cases. I think almost several months we did not find any death cases. So only the challenge during the Delta wave, we see the high number of cases and the high number of death cases. But in Omicron wave, there is still like a high number, but it is not twice or 3 times of the Alpha cases, but for the death cases, it's still lower. And it's seen here more clearly, I think, how the variants are in Indonesia. And in February 2022, I think we are able successfully controlling the Omicron variants, and including now with so many variants. And we see here the effect of reproduction numbers. It's previously it became 3 or 4. Now it's below than 1. It's now like 0.6. And what is our way to control pandemic? Of course, that we implement the public health and social measure. And we have like what we call it adapt and lift public health and social measure. We did not imply the lockdown policy, but sometimes it's like a driving car. Sometimes we have to push the brake. Sometimes we need to lift the brake. So it's really based on the primary situational assessment on the intensity of the transmission, and we've seen the capacity of the health system to respond it. And of course, we call it this our public health and social measure, continuously adjusted according to the intensity of the transmission and the capacity. And it's a combination measure. It's not solely one intervention, but it's a combination of intervention and combination of measure. So that's why we have three main things: is how the government playing a big role in providing test, treatment, and tracing. And then we have how involvement, a strong involvement from the public or from the community, such as health protocol, for example, like wearing a mask, hand hygiene, and of course, physical distancing. And then, of course, lastly, we are really try hard to have very high coverage of the COVID-19 vaccination. So what we learn is first is a strong leadership and commitment. We have really review all our regulatory, including to adjust this policy and organizational structure in terms of we need to have a good leadership and the commitment. And it's a high alert and timely response. For example, at how we strict when we have need to strict the border control, and then we have like quarantine policy at this time, and risk communication and information transparency is really needed because of the challenging, because there is so many misinformation or hoax, and especially we know for the vaccination, and then how to need to change the community behavior is something that really we need to have a good risk communication during the pandemic. It's not only for general public, but including for the health workers. And adequate resource allocation, transmission prevention, for example, for the vaccination and digital vaccine tracking system, and involvement of the citizen for a new lifestyle for the pandemic prevention. And this is what I mentioned. This is a very high commitment from our president that vaccination for COVID-19 will be free of charge for everybody. And then all the national budget, ministry or subnational budget government need to prioritize for COVID-19 vaccination program and all other COVID-19 intervention. And keep encourage people to keep applying health protocol like I was mentioned. So we have like three things in terms of responding to COVID-19. First is we need to detect and then prevent and then respond. This is morely how we prevent infections at the port of entry, laboratory, hospital reference, and community. And then in terms of to reduce transmission individually, that we request keep community to wearing a mask, having a physical distancing, hand hygiene, and of course the vaccination. And the response, we know that we have like testing, tracing, and how to have the case management. And this all strategy need to be very understood by the everybody and by all the stakeholders. It's not only the government side, but including such as an expert, academia, a journalist, and the community itself. So what we do the first, we have like 6 times revised the guideline for COVID-19, of course, because of the new information, the changing of the epidemiology situation, and the adjustment of the policy. And then we have a lot of, in this bahasa, all the flyers that we are sending up to the puskesmas, between at the sub-district level. We have like 10,000 puskesmas or sport health that need to disseminate this information and how they need to change their behavior due to the COVID-19. And then this is like a border restriction. During COVID-19, we have only open like 5 airports, And the seaport is like 5 seaport, and then for the borderland is just like 11 borderland that might changing the population between the border. That's in terms of laboratory for providing testing close to the population. We increasing number of the laboratory is more than 700 molecular labs, and then we have like more 3,000 rapid test sites. This is not only the government for the rapid test site, but including the private collaboration. And for the sequencing, in December 2020, we have only like 16 labs, and to December 2022, if we have increasing number of labs to the 41 labs. And number of specimens that submit to GSAID are increasing too. For the tracing, more than 5,000 volunteer contact tracing personnel are spreading across all the province. The tracer is not only health staff, but including cadre that from community, army, police, and everyone that part of involve all the stakeholders. We have like digitalized contact tracing, and we ensure that all the puskesmas or port health for every cases doing this contact tracing. And it's not only about contact tracing, but how the community are cooperate with the health staff of the tracer is something that really need to be emphasized too, because maybe they don't want to be tracing because of some of the reason. And we know that we have a application, we call it the Peduli Lindungi, is one of the apps that are able to prevent transmission, like more than 600,000 people who are positive or in close contact are able to limit it to have activities in the public area. So we know that from these apps, we do and we can conduct, besides the tracing, we can limit the mobility of the population. And in terms of treatment, we are increasing number of COVID-19 reference hospital, implementation of UP precaution, and then increase knowledge and skill of health staff of the COVID-19 management, because not all hospital staff really understand about this new disease and how to deal and providing the treatment. And then we established COVID-19 emergency hospital, including field hospital in some provinces, converting government building for providing isolation for the population, for the community, and increase isolation ICU capacity for treating COVID-19 patients. And we know during the data we are facing a challenge for oxygen demands that it's almost like 80,000 that are used, and the demands of the oxygen is more than 2,000 tons per day. With the collaboration with the startup, private sector, and the government, we are succeeding providing additional oxygen supply, like 5,000 tons of liquid oxygen distributed to 500 hospitals, 81 isotope donation, and 80,000 concentrator distribute to the hospital, including 36 generator established in several COVID-19 referral hospitals. And for other technology, especially telemedicine, I think activation of these services during we call it isoman or isolation to provide teleconsultation, and we provide free medicine for COVID-19 through these services. We are able, I think, like 1.8 million COVID-19 within 10 months receive the work through the WhatsApp, and then they can connect the link that they provide from the WhatsApp to contact telemedicine, and then they will get like free drugs and free consultation regarding the disease for if they found their COVID-19 positive. So we work together with all the telemedicine company that provide previously teleconsultation services and including the treatment. Other thing is, of course, the COVID-19 vaccination. I think this is our goals. And then what we need to really think is how to priority for key group, because we know very well that the availability of the vaccine is very limited during the beginning of the pandemic, and then but we know with the 180 million people, it's really challenging to get sufficient vaccine. So we really need to priority who will get the first of the vaccine, and then we need to provide sufficient resources, provide easy access to vaccine. You still remember how the judges are challenging in Indonesia. Of course, we need to establish a good distribution too for the vaccine. In terms, we did not want to lose the quality of the vaccine, and then how to monitoring the vaccination, because we know that we need to provide more than one injection for COVID-19 in terms to get the very good immunity. And of course, the clear communication to the public. So this is our stepwise vaccination phase in Indonesia. We start with the health of staff and then elderly. So we start with the very high risk population too, and then to other population. And we conduct a survey before we start the vaccine about the vaccine acceptance and assistance. So we know very well where the area that need to have more information, need to have involvement from the leaders of the community in terms to bring people to get the vaccination. And of course, you know, Indonesia is the biggest Muslim country. We really need to have what we call it the policy from our religious leader about the vaccine, and it's really need to be FDA approval, because this is like emergency use authorization. So we need to really have to clear message that they are not as like something like it just a pilot the vaccine. So it's really vaccine that will make their solution for the COVID-19. And then you know, during Ramadan we cannot stop the vaccine, because we really need to accelerate the vaccination in terms to achieve the herd immunity. So we need to something policy from our religious leader, because during Ramadan or during fasting month, we still allowed to get vaccination, because it will not break the fasting. And then the other thing too, we need to strategize how to increase vaccination rate per day if we want to our timeline to provide vaccination to all the population, and how to implement this vaccination, including who will be provide the access for the vaccine. It's not only government and the private hospital, but we will use like army, police, and then we have like a mass vaccination, mobile vaccination, or even we have vaccination in the shopping mall. That's one. Or even we do like a drive-through. That include the strategy how really to get acceleration on the COVID-19 vaccination. And then we have like vaccination scheme, because we know that many people will come and then it will be crowded, and then how to manage it very well. And then it will not a new source of infection is one of that really need to thinking about the flow of the vaccination. And like I mentioned, this is how the distribution and then how to maintain the quality is one of that really need to be prepared. And recording reporting, we have in mobile, we know that the Peduli Lindungi is not only for prevent the infection, but including the how to get your vaccine certificate. And the availability of many type of vaccine, we did not limit it into one of two platform, but I think we all have the other platform. Okay, because my time is 5 minutes, and then we have conducted a survey to see the proportion of the population and how high the titer of antibody COVID-19 population. And like I mentioned, risk communication is one thing that really necessary. The hooks and then how pushing from vaccine hesitancy to vaccine acceptance. This is, I think, this is all we know how we measure our public health and social measure when we need to lifting, when we have to have intense anti-HM among the community. And transition to pandemic, as WHO guideline, we are preparing because we know that COVID-19 still will be there, and then what we need to have a plan to prevent the next pandemic. Of course, based on all the experience and the lesson learned, now Ministry of Health, we have, like we call it, the transformation strategy that conducts 6 pillars, especially for example, in terms of resilience of the health system regarding the producing of the vaccine, and then development of medicine, drugs and biological products, and then of course the drugs and other medical device, and the health information that our Peduli Lindungi apps that previously we used during pandemic now become the health citizen apps that know community our citizen can have like immunization and vaccine certificate. They have personal health diary. Even they can have like electronic medical record within their hands. Okay, so this is the platform that we have established. We call it the Satu Sehat platform, including the one that transformed from Peduli Lindungi mobile to the Satu Sehat mobile. Okay. Lastly, I think this is the way. I think mobilizing the national health system during COVID-19, we really need to have mobilize all what we have previously. For example, like health program, how our policy in the border restriction, isolation, and then how provide critical wards. And then financing need to be really focused on the COVID-19 pandemic, and then human resource for training, incentive, and recruitment, how to provide drug supplies with the current of the previous logistic system that's still working, that we are really need to focus on the COVID-19 management. And then, of course, the community involvement and information system that previously we have in other countries. So, okay, so this is my last slide. I think what the way forward is now in terms of preparedness and response, we build on the strengths that we have, lesson that we have during COVID-19. And we know that the emergency response is the whole society, a whole government effort. It's not only about health only. And we need, again, to relook to the health workforce, including training, deployment, and then, of course, take advantage on the digital innovation, foster research innovation in terms of preparedness and response, and investment in public health. So we can really have build and sustain a program for the next pandemic. I think that's all I can share. Thank you very much. Over to you, Prof. Vidya.
Thank you so much, Dr. Nadia. That since many of the issues and the experiences that we're hearing, and having been in Indonesia just a few weeks ago, you know, I think it's really amazing, this major legislation that they have passed and a massive health system transformation that is getting underway. And perhaps the COVID experience really brought to political attention how the health system needs to be strengthened. Now let's go to Singapore, a place that's often compared with Hong Kong. Very different in many ways. Lots of interchange, of course, between the experts in Hong Kong and Singapore all throughout the period of COVID. And with us, we have very special guest, Professor Vernon Lee. Vernon is a preventive medicine physician with extensive global health experience. He's the Group Director for Communicable Diseases in the Singapore Ministry of Health. He's also the Executive Director of the National Center for Infectious Disease. And perhaps he will also make references to the post-COVID development, which is the Communicable Disease Agency, where he is the head of the planning office. But beyond Singapore, Vernon has also been working with WHO both globally as well as in Indonesia. So over to you, Vernon.
Thank you so much, Vivian, and thank you so much for the organizers of this meeting for the kind invitation, and very good morning to, very good afternoon, in fact, to our friends in Hong Kong. So I'll start sharing the screen. So today I'll be talking about the preparedness, readiness, response, and recovery of the health systems during COVID-19 pandemic, and how Singapore's whole of society approach to public health threats has put us in good stead for our response during the pandemic. So Singapore has faced significant public health threats throughout the years. I mean, the pandemic is obviously not the only threat that we have faced. In fact, over the past 20-odd years, we have faced quite substantial threats, from the Nipah virus outbreak in 1999, early 2000s, to SARS in 2003, which Hong Kong had also experienced. We had bouts of dengue, chikungunya, Zika throughout the years. We also obviously were hit by the H1N1 pandemic 2009, and in 2019, we had an imported monkeypox case from Africa, which thankfully did not spread thereafter. And obviously, many concurrent infectious diseases threats that we are trying to grapple with. Although we have not had cases of Ebola, of MERS coronavirus, for example, we have also been enhancing our preparedness plans to deal with these diseases should they emerge. In strengthening our pandemic preparedness plan, a whole of government approach is needed. And Singapore's preparedness and crisis management framework is one that relies on a whole of government ecosystem, not just of the health sector alone. It's underpinned by planning and coordination across government agencies, capacity building, and obviously having good national legislation, policy, and financing. In the health arena, we have our Infectious Diseases Act that's obviously supported by many other acts across the government. And the foundation underpins the three pillars of prevention, detection, and obviously responding to an outbreak should it occur. And the National Crisis Preparedness and Management Framework is one that's also been developed over the past several decades. And it is coordinated by a ministerial committee. And during COVID, the ministerial committee was chaired by, in fact, three co-chairs, one from the Ministry of Health, because obviously it's a health sector heavy issue, but the other two co-chairs were the Minister of Finance, because there's a lot of financial issues that needs to be grappled with during the pandemic, especially to provide support, not just to the health sector, but to the whole of the rest of the economy and society. And the third was the Minister for Trade and Industry, because they had to bring in a lot of different things, from personal protective equipment to vaccines and so on. And below that ministerial committee, you have an executive group, and this is where all the permanent secretaries or the head of civil service from all the different ministries would come together to look at how to actually implement the guidance that's provided by the ministerial committee. And within the health sector, you have then the Minister of the Minister of Health would chair a crisis meeting, and there'll be a crisis management group chaired by the Permanent Secretary for Health. And this also includes members from all the different agencies and ministries that would feed into the various health measures that we'll be bringing to bear. And obviously below that, we have the sort of the operational arm of the ministry that will be sort of supporting a lot of the day-to-day operations. So as you can see, it's a huge pyramid structure, and there are many ministries involved at the whole of government level. Since SARS in 2003, we are also looking at establishing the National Center for Infectious Diseases, because during SARS, what happened was that we had to shut down a major hospital in Singapore, Tan Tock Seng Hospital, because it had to house all of the SARS cases, and the impact on the healthcare system was substantial, because if you shut down a major general hospital, then you had to basically reduce your hospital capacity to deal with other diseases that would still occur on a regular basis, especially during a prolonged pandemic such as COVID-19. So since SARS, we have been looking to establish a center that could actually house a substantial number of infectious diseases cases. Obviously, we would require support from the general hospital in terms of other specialties such as emergency medicine, surgery, and a lot of the other things that would be needed to support infectious diseases cases. However, by being able to contain a sort of a mid-sized outbreak within a center, we would then not have to close a major general hospital if we were faced with a SARS-like outbreak again. So the National Center for Infectious Diseases is a 330-bed purpose-built facility that's expandable to 500 plus beds if needed, with a full suite of medical facilities, including surgical capability, its own emergency department, and so on, so that we can actually scale this capacities during the pandemic. And it was actually officially opened in 2019, just before the COVID-19 pandemic hit. Now, Singapore's COVID response is very much dependent on the situation that we'll be faced with, because our response, or the key tenet of our response, was that it had to be proportional to the risk that we were facing, because we didn't want to respond beyond the risk, which means that if the response is too vigorous or the response is not proportional to the risk, then the response measures themselves may do more harm than the actual prevention of disease. At the same time, we do not want to have too little response, because then cases would escalate too fast beyond control. So the response in Singapore actually changed depending on the situation. In early 2020, when we had our first initial few reported cases, and subsequently local cases as well, the response was very much focused on keeping the number of cases low. Now, we didn't actually aim to keep cases to zero, because that would mean putting up a lot of different measures. In Singapore, being a trade and travel hub, we had to keep certain things open, like our trade routes, for example, because we had to continue supplying our population with food, with other things like PPE, and later on bringing vaccines and so on. So while our intent was not to keep cases at to a sort of zero level, we actually did achieve zero cases at a couple of time points. But of course, then cases started increasing again, because we had imported cases from different parts of the world. So initially, the control was quite effective at bringing cases low, especially as China had, in the initial months, shared its sequences to us. They had also reduced travel, and therefore we had been able to keep cases quite low. However, when the pandemic situation spread to the rest of the world, and we started receiving imported cases from many different countries, especially countries that did not even report a large number of cases initially, the situation changed, because we were seeing a lot more community transmission. By March and April of 2020, we also saw cases occurring in our foreign worker dormitories. So these were dormitories that were built to house foreign workers, to provide them with a very holistic environment where they could interact with each other, but are At the same time, the interactive environment also provided a platform for surge in cases. So to prevent cases from surging beyond what we could bear, we actually entered into a mini lockdown, what we term locally as a circuit breaker. And this was to keep cases low so that we could manage them through then all the other measures such as isolation, contact tracing, quarantine, and so on. So after after May and June of 2020, which was our mini lockdown, the circuit breaker, we managed to bring cases to a very low level again. And in fact, again, we hit 0 cases at a couple of time points. But subsequently, in the end of 2020, that was when we had the vaccine. And with the vaccine came a shift in our thinking about our strategy of how to tackle COVID. Because if we could have a vaccine that reduced complications, reduce severity, reduce mortality from disease, that would mean that we could actually live with the disease much like how we live with many other respiratory diseases, influenza, RSV, and so on. And the strategy then was not so much to reduce cases to a very low number, but it was to prevent the healthcare system from being overwhelmed with the number of cases. So we managed to vaccinate a very high proportion of our population by the second half of 2021. In fact, when a Delta variant hit Singapore, about 70 to 80% of our population were already vaccinated. And for those that are eligible, in fact, we hit more than 90%. And the Delta variant and the initial Omicron variant, you can see the number of cases surged way higher than the initial period that forced us, or that made us go into the mini lockdown. With Delta and Omicron, we could bear a lot more cases. We obviously had to introduce some public health and social measures to keep cases in check and to prevent the healthcare system from being overwhelmed. But we're trying to learn with a high vaccination coverage, how much can we bear in terms of number of cases before our healthcare system would be strained. And what we found with the Omicron, the first Omicron wave, was that actually with a very high vaccination coverage, we could actually bear a very large number of cases without the healthcare system being overwhelmed at all. So for the subsequent Omicron waves, and we have many waves since then, BA.4/5, XBB, and even now we're facing a new wave, we realized that even without any public health and social measures, we could still maintain a healthcare system at a very good level because we had built up such capacities. We had built up a very high level of immunity, both from the vaccination and also from natural immunity. And actually, we were quite confident by early 2023 that we could actually lift all measures and life could go back to normal. But we obviously would monitor each wave using both surveillance systems and also predictive modeling techniques to be sure that our healthcare system would not be overwhelmed. So during the entire COVID pandemic, the healthcare system was strained, was stretched at certain points, but it was never overwhelmed, which means that everyone that needed a hospital bed, everyone that needed an ICU bed would get one without any delay because the healthcare system could cope with those surges. So the key domains of Singapore's COVID-19 response were across these 7 key areas. One, of course, border measures. Many countries had put them in place. The other that I mentioned earlier, surveillance, plus that test, trace, isolate or quarantine, depending on if you're on case or contact. Then all the safe management measures, which were our term for the public health and social measures, expanding treatment capacities, having a good vaccination program for the public communications, which are two-way, and I'll talk about this later, and obviously research, because all of our policies were based on evidence. And there was shift in these measures, as I mentioned earlier, depending on the situation, and we had to be nimble to deal with the changing situation. So some of the things that we've done in terms of border measures, initially, in the initial first few months, we were, in fact, tightening our borders and putting in more border measures because we wanted to reduce importations. But later on, when we had a highly vaccinated population, and we knew that we had to reopen our borders because Singapore relies a lot on trade and travel, and we can't keep our borders closed forever. Because if not, if the COVID virus doesn't result in a huge impact, the closure of borders for very long will result in huge social and economic impact. So we took a risk-based approach to border reopening, launching initially with a vaccination travel framework to a few countries to have a view on how the travel framework would work. And this meant that those who were vaccinated did not need to be quarantined on arrival, whereas those who were not vaccinated would require testing and also quarantine on arrival. And we sort of modified this across time. And by 2023, early 2023, we were confident enough to stand down all of the different measures that were available. Then surveillance was the other thing, because if you don't know what you're dealing with, you can't actually deal with it. So you had to be confident that you are able to see the virus and its transmission in its entirety. So we based our surveillance on two different aspects. One was looking ahead, looking overseas, what's happening. So this is keeping tabs on emerging variants and what our local susceptibility is, so that we can anticipate what future waves look like. So global surveillance would include working with the WHO, with different countries and different partners all across the world to see what are the emerging variants. Serologic surveillance to look at our local immunity and also our local vaccination coverage, and also monitoring of vaccination rates. Then looking within, doing genomic surveillance in Singapore and looking at new technologies such as wastewater surveillance, which provides an additional sort of a measurement that is very different from other sentinel or case-based surveillance. So by having different surveillance modalities, we are able to cross-validate the data that we have. And of course, now we've moved more towards community sentinel surveillance, since we do not need every single case of COVID to be reported, because the sentinel surveillance enables us to still build that epidemic curve and also to predict what future waves might look like. The other key domain was the test, trace, isolate, or quarantine. Initially, to keep cases very low, and that was a containment phase with rigorous contact tracing. All close contacts were quarantined and tested at government facilities, and we expanded testing around clusters of interest. But as we shifted towards one of resilience and to mitigate spread more than to actually contain spread in entirety, we took away mandatory quarantine. We asked people to have self-responsibility. If they're unwell, see a doctor. If they test positive, they can self-isolate. And if they have been identified as close contacts, for example, a family member, they could still go out, but just to take a test every day, so that if they test positive, they can then self-isolate. And of course, once we were confident that we were able to withstand the subsequent Omicron waves without any interventions, we stood all of this down. But we also tell the public, even up to now, to be socially responsible. Expanding treatment capacities, apart from the National Center for Infectious Diseases, which was able to house the first few hundred cases in Singapore. But subsequently, of course, COVID-19 had a lot more cases, and we had to expand treatment to all acute hospitals and open up all ICUs, because COVID-19 did not need to be treated only in a single hospital. We want to open up the facilities across not just the public hospitals, then into the private hospitals as well. What we also realized was that many cases did not require acute hospital, tertiary hospital care. What they required are facilities for monitoring, especially, for example, if they were elderly, or for isolation if they were not able to isolate at home. So we built many community treatment and isolation facilities where people could recover there with very minimal clinical supervision that freed up the hospitals for the more severe cases. And we also set up a home recovery program where people can recover at home, but have access to teleconsultations and a doctor that would be on, or medical team that would be on standby to provide teleconsults should they be needed. And we also had about almost 1,000 public health preparedness clinics. And these were not clinics that were stood up during the pandemic. In fact, the public health preparedness clinic system has been around again for many years. And the whole idea is that to have a system of clinics that were ready to take on pandemic patients without then affecting the other clinics that would be able to deal with cases of sort of non-communicable disease cases, so that the acute respiratory infection cases and the other cases do not mix. Then, of course, the public health and safety measures, as I've mentioned, that were adapted across time, and we stood this down in early 2023 when we realized that these were not necessary. We also use many different technological platforms, such as our Bluetooth-based contact tracing app, and also we use the same app for checking into different places. And in fact, the use of this app and the ability for us to adjust our measures. For example, when we first opened up more society after the mini lockdown, we necessitated the checks of vaccination status. So only people who are vaccinated were allowed to go to, for example, to enter the malls, to dine at a restaurant, and so on. And this also had an added-on effect, because in Singapore, people like to go to the malls for shopping. They would like to dine out with their friends. So if they were unvaccinated, they could not participate in these activities. So by having these vaccine-differentiated public health and social measures, and by use of this app, we increase the vaccination coverage to a very high level. On vaccination, of course, the government played a very central role by providing free vaccination, although vaccination was not mandatory. By having all these measures, we were able to increase our vaccination coverage through many different means. On the chart on the right, you can see that our vaccination coverage as of a couple of months ago is more than 80% that have attained minimum protection. And minimum protection in Singapore is defined as having at least one booster on top of the primary series. So we have set a higher threshold, higher bar for ourselves, because for the primary series itself, we have achieved way more than 90%. So we keep setting higher bars, and now we have also provided another definition in terms of up to date. So there's minimum protection, but also we want people to be up to date with the latest vaccine. So in terms of how do we increase vaccination coverage, we have many different vaccination centers all across the countries to increase access. But also what we realized through a lot of our surveys was that there are many of the elderly and many other individuals that were hesitant to get a vaccine, not because they were anti-vaxxers, but because they didn't have the ability to obtain information that we put out to the media for various reasons. So we reached out to these individuals through the grassroots leaders and grassroots volunteers, because these were people that the elderly trusted to get information. And these grassroots volunteers had already been befriending the elderly, even during non-pandemic, non-crisis period. So once they convinced the elderly of the importance of getting vaccination, we had the mobile teams to go in there and vaccinate them. So this worked very well because we gained the trust of the population, and we were able to go in and get vaccination up to speed very quickly. And then, of course, research, evidence-based decision-making, whether it's things like mask use, vaccine effectiveness, public health measures. We launched many different, what I call operational research programs and activities, so that we can get data quick to enable us to formulate policies with as much data as possible. Obviously, we're never going to get complete information. There's a lot of fog of war, but as much information as we can glean, it is very important to allow us to make policies with our eyes open. And so we had many different initiatives with academic institutions, and even many institutions overseas in terms of exchanges, so that we can have as much information as possible. And finally, public communications. And this is where we focus on two-way public communications. Obviously, we had to put out a lot of information to drown out a lot of the misinformation that has been out there because of the advent of social media. So we had to also use social media to put out a lot of government's position and a lot of the truths. At the same time, there were polls that were regularly conducted, not just during the pandemic, but these were polls that were conducted even in the peacetime period. But we wrote on those polls to get a feedback. For example, what did the public want? What were their fears? What were their needs? Or what were their concerns? So there were certain points where we were prepared to release or relax certain measures, but the public might not have been ready because there were so many changes, and we delayed some of these measures so to focus on what the public could bear. So what were some of the lessons learned from COVID? And this, if you can just bear with me for the last few minutes. The first is that a pandemic preparedness plan has to be nimble, has to be able to adapt to the unpredictable landscapes of any novel pathogen. So COVID-19, we saw, is a pandemic for 3 years. There were a lot of things that change, and our system, our response has to change as well. And this would definitely be true for future disease X. And the future disease X may not even be a respiratory pathogen. We have to be able to be nimble. And I would like to use an analogy. It's like Lego blocks. We all play with Lego blocks at some point in time in our lives. Maybe some of you still play with Lego blocks currently. Lego blocks are fascinating because with a few combination of different blocks, you can build a house, you can build a car, you can build an aeroplane, you can build a ship, you can build many things. So all you need is those few building blocks. And what we are now telling our agencies is focus on those building blocks. For example, for border agencies, things like testing, things like enacting border controls, quarantine measures, and so on. And depending on the pathogen, we can mix and match those few blocks to come up with a response system that is proportional to the risk that we are facing. Because it is impossible for us to have 1,000 different plans, one for each disease, and many of them will look very similar. So just those building blocks will put us in good stead. The other is peacetime preparedness is crucial. You can't prepare for something during a crisis itself. It's not possible. So post-SARS, we had a National Center for Infectious Diseases, and we strengthened our crisis management system. Post-COVID-19, now we are in the process of forming a new communicable diseases agency where we will bring together all of the different public health expertise from the Ministry of Health, the National Center for Infectious Diseases, and other parts of the government system to form a single new agency that will have the full command and control coordination of all aspects of the communicable diseases preparedness response system. And obviously, our expansion of our National Respiratory Infection Surveillance Program, which we will be strengthening so that we can detect emerging pathogens early. The next is that being operationally ready is vital because there's no point preparing if you're not ready to respond. Because preparedness is something that's done on paper, but you must be able to exercise those plans, be able to put in place all the operating procedures and test them so that when something happens, you know that the system is warm, the system is ready to react very quickly, because quick reaction and quick response is what's needed to reduce the impact of any pandemic. And finally, as I mentioned earlier, the importance of two-way communication, because while information dissemination is crucial for transparency, and this is something that's very important, we must be transparent in our communications. It is also vital for us to understand the concerns of the public. Then we can put out information that is what the public wants to hear and what the public needs. Fostering trust will take a long time, takes a long time. But if we do it wrong during a crisis, that trust can be very quickly eroded. And therefore, it is very important for us to understand what the public wants, what the public needs, and what the public concerns are, and to provide them with the appropriate information so that they can be compliant and can be on our side when it comes to our public health response and our public health guidance. Thank you very much.
Thank you very much, Vernon. I think that's a very interesting overview of where you've been and where you're going. We have a few minutes. We are open to questions from the audience, if anyone has any. Yes, please.
Professor Lin, this is S.V. Low. I have a question for Professor Vernon Lee, and also thank the three speakers for their very insightful presentation. My question centers on the decision of the Singapore government opening up, adopting the policy of the coexisting with the virus. And when we look back, that was definitively a very correct and courageous decision. But at the time when the decision was made, you are still dealing with the changing nature of the virus. And could you perhaps share with us your thoughts on how confident were you when you were making that very bold decision at the time, knowing that you have a very good vaccination rate amongst the highest in the world, and you have got all the other infrastructure in place. But the nagging question is that when you make that decision of living with the virus, you may take your population down to a very disaster path. So could you share us perhaps some insight on this? Thank you.
Yeah, thank you. So it certainly was a very much deliberated decision. And it also wasn't sort of a, from one head on, one day we were in containment and next day we just release or relax everything. We didn't do that. So we did it on sort of three different levels. One was that we collected all the available evidence. And we did a lot of modeling exercises, mathematical modeling, disease dynamic modeling, to see what would happen if we relax some of those measures, if we have very high vaccination coverage. And we also found that if you have very high vaccination coverage, we had evidence to show that although people might get infected with COVID, it was a lot less severe. The hospitalization rates, the ICU rates were very much lower. Therefore, we were confident that if we did so through the modeling, we would not face a situation where hospital or ICU beds would be overwhelmed. That was the main key point. And at the same time, we didn't know for sure, because with any modeling exercise, it's not crystal ball gazing. You don't have a certain, certainty for anything. So you have a lot of confidence intervals, and they may be quite wide, as you can imagine. So what we did is what we commonly term as a plan, do, study, act cycle, PDSA cycle. So we release things bit by bit. So we plan on, okay, well, what could we release a little? That's why we came up with things like, okay, travel. We came up with a vaccination travel framework, maybe to a few countries. For relaxation of, public health social measures, we enlarged group sizes. Initially it was 2 people, we went to 5, we went to 8, but we didn't release it immediately. And so on and so forth, while people going back to work and all that. We retain mask wearing, for example, because that we felt was something that signaled that, things weren't fully opened up yet. So we did those things, we studied it, we collected more information, and we looked at what is the impact. And when we realized that we could open more, then we did so stepwise. However, the virus would always throw curveballs in us. We had the Delta variant, and then we had the Omicron variant. And every time the variant comes, we saw cases going up. We did our modeling. We said, okay, maybe we shouldn't open up so quickly because there's a new variant. Sometimes we had to impose a little bit more restrictions. So it's a bit, of a little, wave. But slowly we were moving towards the final outcome. And once we studied and we collected information to show that even with the Delta and Omicron waves, we managed the situation quite well. When the second Omicron wave came, we were very confident that we did not require all of the different measures and we could actually open up our society and economy because we had collected enough information through the few cycles. So it's a very deliberate action. It was not that we woke up one day and say, let's move from 0 to 100 immediately. We went from 0 to 20 to 50, then maybe going back to 40 and then so on and so forth until we were actually confident that we could do so. And so we did that way. But even then, even up to now, we retain all of the ability to impose measures should something else happen. For example, more severe variant of concern that might emerge in the future. We always need to be ready to respond if the situation takes a turn. Thank you.
Thank you. Other questions? Yes, one in the back.
Thank you. I have one question from as we know, when pandemic concerns, when pandemic affect, all health service is disrupted. And how the local government integrate palliative care during COVID-19? Thank you.
That was a question for who? for Dr. Nadia, was it? Or Dr.
I think for Hong Kong.
For Hong Kong, Dr. Yeo.
Hong Kong, yeah.
EK? Here's the mic.
Dr. Ronald has left. But from our the knowledge that we have, obviously during the pandemic, there a lot of the services were suspended, and palliative care obviously was one of the things that was also affected in the context. So many of the things that were not, because that's issue about the resilience part. The whole system was overwhelmed, so the priority was really for the key essential services. So I think in palliative care, obviously some of the things continue, but many things were shifted for other services.
Yes, Irvin.
Hello, I'm April from Chinese University of Hong Kong. I have a question for Dr. Maria. It's quite impressive to see that Indonesia government introduced a lot of measures such as vaccination and test, and also engaging the community to deal with to combat COVID-19. And actually, my question is related to the one about the interruption of healthcare services. So we know that Indonesia has made a significant progress in achieving universal health coverage, but during the pandemic, so a lot of healthcare services actually has been interrupted because of the overwhelming health system, and also because the government has been distributing a lot of resources to come back to COVID-19. But from your presentation, actually, I kind of also see some opportunities, because you introduced that the government actually has been able to kind of strengthen the health system. So my question is about achieving universal health coverage. In the post-pandemic era, do you see more challenges or opportunities in achieving universal health coverage? Thank you.
Thank you for that question. So I think first, in terms of universal health coverage is showing an important role even during pandemic COVID-19. Of course, during pandemic, most of the finance are the government responsibility. So it's not national insurance to cover it. But after the pandemic, we still see some of cases, and for the high-risk group, they still need treatment in the hospital. So it's really important to have them, especially who are high risk, is have protection through the national insurance. During the pandemic, of course, like Professor Vernon said, that many services are interrupted, but we still have like 10% up to 50 or 60% of the routine healthcare that still can be accessed by the patient, for example, including the palliative or even any treatment, regular treatment they need to have. But maybe, for example, usually like a hypertension patient, usually they come like 2 weeks or 3 weeks now, and they need come to the health to the hospital like 1.5, or we can ask the health staff to deliver the drugs, or we can use the telemedicine as one of the way that we are deliver the service. So and of course during Alpha and Delta, almost 90% hospital and health facility are focused on the COVID-19. But after that, we know the burden is decreasing, and then we start again to provide any health services. And at that part, the universal health coverage are play their role. It's not only for COVID-19. I mean, when we have COVID-19 waves, the health services which not related to the COVID-19, still covered by the universal health coverage through, like I mentioned, telemedicine or through the routine health facilities, and then by the way how the patient to visit the health facility, it might be we are regulated. So I think it's really important in terms of especially preparedness and response. And we know that the pandemic, it will not stop here, and the COVID-19 still mutate. Whether there will be a new variants that will affect us. So universal health coverage is one of the way in terms of reducing the burden for the population.
Thank you very much for that. I think that we have come to the end of our time. So can I thank Dr. Nadia, Professor Vernon, and our New South Wales colleagues who've had to actually leave to attend another meeting very much for sharing their experiences with us. I think we can see some of the similarities in the responses and how every country has lessons, move on. And maybe we need to all go out there and buy ourselves a Lego set so we're ready for disease X. Thank you.
Thank you.
Thank you.
Thank you, Professor Lin and our fellow presenters. Now that concludes our morning. We'll be having our lunch break. Lunch will be served again in the foyer. We'll also have poster presentations just outside the auditorium here on the first floor. Please take the time to check them out if you haven't, and take the time to talk to the presenters. A gentle reminder that there's no eating or drinking in the auditorium, and we'll be reconvening back here at 2 p.m. When we're back, we'll be moving on to the plenary session right away because something has come up and Professor Teodoro Herbosa, the Secretary of the Department of Health in the Philippines, will not be able to join us this afternoon, unfortunately. So yeah, we'll be moving on to plenaries right away after lunch. Thank you and enjoy your lunch.
Thank you, Vivian. Sorry.
That's fine. We're always
Thank you, Professor. I think really learned a lot. Okay. Yeah. I'm super interested in the report that
you.
I hope you've all had a great lunch. Welcome back, everyone. Our next plenary session is on operational level resilience. We are excited to have experts across the region to share their experiences on the operational resilience from the COVID-19 pandemic. We're so honored to have Dr. Suvi Lo, the Chief Executive Officer of Hong Kong Genome Institute, to moderate this session for us. Let's give a warm welcome to Dr. Lo.
Thank you. A very good afternoon to all of you. This is the plenary session on operational level resilience. And this afternoon, we are very privileged to have three distinguished speakers sharing their country experience on operational level resilience in managing COVID-19 pandemic. Our first speaker is Professor Dr. Laksono TRISNANTORO. I hope I have correctly mentioned your name. Professor TRISNANTORO is a professor in health policy and administration and a senior researcher at the Faculty of Medicine of the Universitas Gadjah Mada, Indonesia. He is currently the special advisor to the Minister of Health and serves as a board of director of the Asian Network for Health System Strengthening. Professor TRISNANTORO is a renowned scholar and an esteemed practitioner of health policy and administration. Worthy of special mention here is his unique experience in operational level resilience, in which he directed supporting health services to post-tsunami residents in Aceh and North Sumatra from 2004 to 2008. Professor TRISNANTORO is going to share with us operational resilience in COVID-19 pandemic in Indonesia. Professor, please.
Okay. Okay, thank you very much, moderators. Yes. Ladies and gentlemen, good afternoon, everybody. Yes. Okay, I have to admit that this is not a good time for speaking after a very, very heavy lunch. Yeah. But let's do this presentation about the operational resilience in COVID-19 pandemic in Indonesia, and this is an observational study on health system strengthening. So if we look at back to the issue of resilience, then this is the knowledge event from Asia Pacific health system strengthening. That means we have to learn from our experience how to make our 3 years of pandemic becoming a good starting point of new movement or new era for health system strengthening. That is my point. Okay, so we have some issues to be presented, and we will discuss over that about the preface and then what's happening in Indonesia's COVID-19 policy or operations. And this morning we had heard about the experience from the overall health policy in Indonesia, and I'm trying to focus on the operation aspect of COVID-19 policy. And then the analysis for lesson learned and the closing for the future. Okay. Okay, let's start with the preface, and this is the framework that coined by the World Bank, and it is very interesting that if you look at back to the issue of pandemic, that is a matter of how the performance of health system can be like disturbed or suppressed by a big pressure. And if you look at back to this graph, it's real that when we have a pandemic, then the system will declining the performance, and then by the time the system will absorb and then trying to recover it back from the shock of the pandemic. And this is the issue that there's a big capacity or small capacity of operational resilience in the system, whether we can make a speedy and a good recovery of health system performance. And this is a big question of how in Indonesia the resilience will be, or the experience will be discussed. And then this framework is very nice to look at because like the awareness of the pandemic before it is started here, and then how the absorption of the shock that can make, and then the transformations after the COVID or after the pandemic. And this is the things that I will try to make some analysis on the issue of how the future will be developed in terms of health system strengthening. Okay, so this is the response. So if we look at back to the issue of the main policy, we have the current, the very, very timely presidential regulation on the Republic of Indonesia number 82, year 2020, concerning the Committee on Handling the Coronavirus Disease or COVID-19 and the National Economic Recovery. So we have two prongs of the committee. One is to deal with the health shock, and then secondly, it is a parallel work is how to like recover the economic problems through the pandemic. So this is like two prongs of the strategy. And this is the integration of health and economic strategy, the main things that we try to develop in the beginning of pandemic in 2020. And this Indonesia is a huge country and an archipelago, more than 30,000 islands. It is different with Hong Kong, I think. Hong Kong, how many islands? 1,000, yes, 100 islands in Hong Kong. But this is 13,000, and the size is from, say, this is Madrid in Spain to Moscow in Russia. So it's a big country. Okay, and then the statistic of COVID, we have about 6 million out of 270 million people confirmed cases, and we suffer from 160,918 deaths during the pandemic. That's we had 3 peaks, and then the Delta variant is the most or the deadliest virus. Okay. Sorry. And then how the representations of COVID-19 pandemics in Indonesia. Before pandemic, that is the starting point, that we don't have enough pandemic prevention, preparedness, and response. It was not integrated to health system resilience. And then the health governance was not too good and not too aware of threats. And then during pandemic, and this is the things that in the operation, we learn from our mistakes. So in the beginning of the pandemic, we started with many, maybe so-called like a trial and errors. But after some months, and then we have more knowledge, more experience, and also the global progress of COVID-19 alleviation is also becoming better and better. So in the last 2 years of the pandemic, we have a very detailed policy of absorbing pandemic impacts. And this is very important, adaptive to minimize disruption. And then in this period of time, the operations management skills were widely used. Okay. And then post-pandemic, now yes, I think we managed to get through the pandemic with good handling performance. And we, for example, we vaccinated more than 440 million vaccines across 275 million Indonesians. And then the operational is good, and the expenses in pandemic program is used for transforming the health system in the future. So this is the things that we learn from our experience. Although the experience is not so good at the beginning, but at least we can use it as a what we call like a tools, or maybe basic for transforming the health system that before the pandemic was not so good. Okay. So this is the things that then I try to make some like small research. This is like observation research about what are the lessons learned in Indonesian response in health system operations, resilience. That is again back to the issue of we have so many things in terms of activities, but how we can make the lesson learned from these 2 or 3 years experiences in pandemic handling. So the methods in the first one until December 2020, we have the participant observations, and then phase 2, and this is thing that I will offer to our network of Ike is how to make an expert analysis about what are the health policy and management lesson learned from the COVID-19 pandemic across the countries. So we can see how the Indonesians experience, the Singaporean, Hong Kong, and then maybe the Philippines and maybe Thais, and then we can compare is it there's a similarity or not across the countries. Okay, so this is the result. What's happening in the operations? So we can see in this slide that there are so many operation strategies, and if we are asked whether it is planned or not, actually we can say that it was not in plan, but it is like a combination of how we try to operate some interventions because we have to do this. It's a mix of many activities, but we can say that the backbone of the pandemic management is back to the sciences of health, epidemiology, biomedics, clinical medicine, and also public health. But it is implemented with so many sciences beyond health sciences. It is supported by experts in informatics, logistics, and then also the mass mobilization of human resources for vaccination, voluntary groups, social scientists, and also economists. They work very, very hard to try to solve the problems. Okay. And then if you look at back to the issue of this is pandemic is caused by health. But it is, if you look at back to the issue of this health, we have many, so many things about health, including how to tackle the surge capacity in the hospitals, and then also on the adoption of COVID-19 vaccinations. But also we like innovate many things in IT, like how the COVID cases are recorded, identified, and this is in real-time activities. So transparency about the cases from province to province is in a real-time modes. And then the vaccine distribution and utilization also monitored by real-time IT system. Also the COVID-19 drug shortage was managed properly by a good IT system. And many things about the logistics in COVID-19. Also, this is the mass mobilization of people. You can see there. I think hundreds of thousands of people, they are active in vaccinations. And then this is very interesting issue that many social scientists, they are also working together with health scientists, including this is a social behavior expert, because we can see that, I don't know, in Hong Kong or in China, maybe you are not so bad in terms of so many, we call like opinion against or for vaccination, for example. And then whether this is a conspiracy theory or it is a curse from the god, something like that. So it's so noisy, especially in media, social media. I don't know in China, maybe China is more quiet, but in Indonesia it's very, very noisy. I think the same is the US experience in terms of social behavior in expressing opinion or perception about COVID-19 pandemic. And then this is the important issue, the second prong of the activities about the economic strategy. And we have the economic contagion, but also we have increased health spending. So both phenomena make our economic situation becoming deprived. And then many leading economists, they said that this is the chance for Indonesia to make what we call like opportunity, not only help but also to subsidize people for having like social assistance, something like that. And we have to borrow money from the overseas sites like the World Bank, and some of foreign countries also provide some grants. And this is the things that we have increased government spending, but reduce government revenue. So we increase our net debt, and then this is the trajectory of the financial effect of COVID-19. So if you look at back to the issue 2020, we have, this is the fiscal space for welfare and other programs include COVID-19 management here. We have a bigger fiscal space because we borrow some money, but automatically we have to pay back. So the interest in the years after COVID, is increased until 2025, and then this reduce the fiscal capacity. So this is the trade-off of we have very quick financial support from overseas, including lending, but also we have to pay after that. Again, this is very, very dramatic. But in terms of operational resilience, we have to do this because we don't have enough resources for vaccinations to provide 400 million doses of vaccine. It is a huge amount of money, and also for the social assistance to the poor. So trillion of rupiah is spent for them. Okay, so the analysis for the lesson learned. There are three things that I try to raise the issue. One, that the experience of the COVID-19 proves that the handling of health problems requires the support of sciences outside of health. And then secondly, we have to look at the approach of transdiscipline, because so many sciences work in the pandemic COVID-19, but how to make decisions, then this is the transdiscipline approach. And then about the third, about leadership, how we can find strong leaders that can or who is able to manage the various skills in making decisions under uncertainties. Okay, so if we can look one by one, I don't have time for this detailed analysis, but actually back to the issue that we have to rely on not only one science, but many science, and we have to rely heavily on the principles of operational management discipline, but under limited time pressure and the uncertainties of pandemic disease and its risks. Okay, so this is the lesson learned. We try to recover and build back here, and this is very interesting issue that we have so many innovative operations during pandemic, but not in health science. So we can see in these activities we have so many support from other sciences and becoming innovative ways of doing things in the future. And then the second analysis, this is a transdiscipline approach. So we can see that we have so many sciences like biology, economics, maybe social sciences, but in this COVID-19 pandemic, we have transdisciplinary. Actually, all of the science becoming one, and we have to make decisions based not only one science, but like the amalgam of many sciences. I think it is difficult to make a scientific description about the amalgamation of the sciences, but this is like an art, so we can discuss it further maybe in the next year's meeting about how we can look at the transdiscipline decision making based on many branches of sciences. It's not easy, but it is happening. Okay, like many scholars in Indonesia also mentioned about this multidisciplinary and also what we call like a transdisciplinary. And then analysis number 3 is what kind of leaders. So we need leaders who are mastering skills like operational management sciences, communications, promoting community engagement, that they are very noisy, yes, and then transparency in the progress of pandemic, and discipline in making a decision. And in recent experience, we have a very strong leadership, and one of the strong leaders there, he is a retired army general, so he is very maybe keen in making decision under pressure, and I think he is happy to do this. Yeah, and also the Minister of Health, the new Minister of Health, my boss, he is an expert director. He is not medical doctor, and expert in IT, expert in operation management. So not medical doctor is very important issue. Okay, so also we have to have local government leadership as well. So as the closing points, I try to make two sentences. That one, the use of operation management skill and transmission approach was clearly used in handling COVID-19 pandemic in Indonesia. And the operational resilience in COVID-19 pandemics needs beyond the health services, which requires cross-sectoral partnerships across government organizations, civil society, and partners, such as the private sector. So it is not only health matters, but everybody matters. And then to improve operational resilience as one of health system strengthening, Indonesia needs to invest in stronger health system, especially in public health institutions, health promotions, community engagement, disease prevention, and primary health care. And then strengthening the operational resilience through the application of operation management health system during pandemic and normal conditions. And then developing the skill of transdisciplinary approach in health system policy that make a decision based not only one science, but multiple sciences. And then nurturing leaders who are capable for managing the complex situation during pandemic or normal health system using transdisciplinary approach. So I think this research should be developed further on the second phase of this research next year, and I hope that we can work together on this development. Thank you very much for your attention.
Thank you very much, Professor TRISNANTORO. Can I just remind our audience here that we will be having Q&A time after the presentation, and our speakers will be sitting just in front of you. And I encourage you to formulate questions along the line of operational resilience. And you have heard from Professor TRISNANTORO that public health is public wealth. And when we face public health threats such as the prolonged pandemic, our well-being of the as well as the wealth of the individual citizen is actually compromised. And in terms of resilience, how do you respond to the threat? And how do you recover and then adapt to the new situation? So this is the kind of question that we need to think through. And question would be very welcome along this line. Our second speaker is Professor Chant, Ying. Professor Chant is the Professor of Health Technology Assessment at Fudan University School of Public Health. He is also the Director of the National Health Commission Key Laboratory of Health Technology Assessment, as well as the Director of WHO Collaborating Center for Health Technology Assessment and Management in Shanghai. Professor Chant is also the Associate Dean of the Fudan School of Public Health, responsible for international collaboration. Professor Chant has focused his academic interest on health technology assessment, health economics, as well as hospital management and health policy. He is actually a very prolific researcher, having authored some 200 publications as first or corresponding author. Congratulations. And he's going to share with us the mainland China's experience on operational resilience in COVID-19 pandemic. Professor Chant,
Okay,
Please.
thank you. Thank you, Professor Low, and I also appreciate and EKU's and the invitation. So it's a very pleasure and to just share operational resilience in COVID-19 pandemic in China. Actually, I just try to use my specific and perspective, academic and insights and from my research and just present and how China or Wuhan or Shanghai and do some operation resilience and in the pandemic. So I have a four part and the first is just the China's response to COVID-19 in general. And the second is just like cases, experiences of collaborative efforts in Wuhan in the beginning of the 2020. And the third, I think, and is related to my academic area, and that's the HTA, Health Technology Assessment. So how HTA informing policy making in this pandemic. And finally, just a few thoughts and from my perspective. Okay, I think, and I would like to just use the WHO. That's the kind of a system and the components and also the goal and as the first and just the structure of my presentation. So I think in the domain of those kind of a thing and for the universal health coverage and cover efficiency, equity, quality, accountability, but also sustainability and resilience. So I think we cannot just look at the resilience and we should put them together. But I think before the pandemic, maybe the resilience is not hot topic, but after the pandemic, I think that's a very important component of those kind of health system like structure. So I think the final goal is kind of improve our population health and what kind of satisfaction and also the other, that's kind of a goal. But we have a lot of kind of a function like a service delivery, financing, governance, but also technology and also information and also other things. And I think that's maybe, and we put them together and think about how to just restructure our health system and make it more resilient and for those kind of outside and just urgent and just challenge. Okay, the first is just very briefly, China response to COVID-19. And here I just like after Wuhan, that's just a global COVID-19 pandemic and by the March of 2020. And that's mainly is in the 2020, you can look at COVID-19 in China and how many cases, mainly in Wuhan city and in Hubei provinces. So there are so many and confirmed cases and how many and deaths occur and how many cured cases and the total those traced and close contact. So that's just show that's the situation. For such kind of COVID-19 pandemic and outbreak, I think, and the first, like the other speaker mentioned, I think the government and that's a commitment is very important. So in China and the central government launched a national emergency response. So I think established the central leadership groups for pandemic and the response and the joint prevention and the control mechanism of the state council. So in that and under the state council, there are 9 working groups. So I think that's kind of just from the governance structure and how the government and try to respond to those pandemic. So including the coordination and the pandemic prevention and the control, medical treatment, research, public communication, foreign affairs, medical material support, life maintenance supplies, and the social stability. Each working group has a ministry levels leader, and the response was organized at multi-level from the national, provincial, municipal to county, district, and also the community level. So I think from the operational and their perspective. So I think those kind of government structure, not just at the central government, but also just through the hierarchy and to the grassroots. So I think that's also very important. And the early stage, that's just the other kind of just a demonstration of those kind of a government commitment and the unified commanding and the system because of time, and just skip that. The other, I think, financing is also very important for the Wuhan and that pandemic and outbreak. And from the nationwide and the government have allocated more resources for the pandemic prevention control, and so that's just a different time period and how much money and allocated to the pandemic, and that's the prevention and the control of the medical treatment, also the Hubei province, but also the Wuhan cities. So here just show that's a rapid and policy guidance, and just always updates and through that's a pandemic and the exchange. So I think, and the first slide just show that's different kind of diagnosis and the treatment scheme, and just for those kind of prevention control also have alternative and scheme, and just try to guiding that's the COVID-19 prevention and also treatment. So I try to use some crisis management theory and just analysis, and similar with and EK use and present. So here's the 4R crisis management, including recover, readiness, response, and reduction. So that's, and we can look at why a different kind of a crisis management and actually is different kind of a tool, like authorized commanding and tool, capacity building tool, and the symbolic and the persuasion tool, and the promotion, and also reward incentive tool, but also the system reform tool. So that's kind of policy have different kind of type, and try to just meeting those kind of different kind of crisis management and component. So here just showed what kind of 4R reduction and readiness and response, and also recover. A little different with and we present, but I think that's also and helpful for us and to think about how to do those kind of operational resilience and management. So one academic and also analysis, China's that's some policy, so different stage like a reduction. We can look at actually the most important actually is just a capacity building, but also environmental creation and also management strategy. But the readiness maybe is monitoring and the early warning, and actually that's policy, including that's the 87%. But the responsiveness and actually resources security, and that's 30%. And the recover, and you can see, and the resumption and work of also the production, that's policy and more and policy. So I think that's a different stage. Actually, we have different kind of strategy, have different number of policy, and also different kind of book size. But I think that's also help us and think about how to do the operation and to just combat that's the pandemic. So that's just the policy iteration according to those 4R models and in the different time stage. Okay, the second part, I would like to just share experiences of collaborative and efforts in Wuhan. So I think, and similar like previous speaker mentions also mobilization. And I think and in Wuhan, mobilization is just a very good cases and for how to just fighting with the pandemic. So here I just look at like the first is the human resources mobilizations. So like by the March 1st and 2020, a total and the 344 medical team and were dispatched nationwide to Hubei with a total of 42,000 medical staff, including 11,000 doctors and 29,000 nurses. So, and also I know including some manager and just support and Wuhan just combat with the COVID-19. Among them, and 38 that medical staff were assistant in Wuhan. And I think that's human resources. You can look at those fingers, and so different date and how many and the cases or just present and how many, and that's the medical and the team and the support and the Wuhan. I think I think not just human resources, but also some medical devices or medical equipment. I think in the COVID-19 in Wuhan, I think the most that's very useful and the equipment ECMO. So you can look at ECMO, and the first stage only 48. That's Hubei. But you can look at and end of the March and 100 ECMO already in Wuhan. So those kind of medical equipment and suddenly and increase and through different kind of support. But that's including those public and the support and the government support, but also some is private sector and also donate those kind of equipment and to Wuhan. So that's kind of mobilization. Maybe is kind of very good and that's a measure and just compare those kind of a COVID-19 or pandemic. And this slide and showed just ventilator that's in Wuhan, in Hubei provinces, but you can also look at different days, how many and ventilator, and that's Hubei have. So that's health resources mobilizations. And also those kind of health resources mobilization, that's kind of use different kind of, that's also the ECMO and ventilations. But also its guideline is very important. But I think that's mainly its guideline is just give just like a triage that patient and different kind of group. Like here is some normal type, heavy, critical, and different kind of way, and just to treat different kind of patient. Some is severe, and we critical ill patient, and some needs ICU, but some not. Some need hospital, but some is just like depends on the Fangcang. So that's kind of a different type of classified, and that's operation is also very important. So you can look at that's China's and control protocol already have such kind of classifies, and that's the just kind of measures and to treat those kind of patients. So here and also show that's kind of mild and moderate, severe, critical, and the health care facility in Wuhan, and 16 shelter hospital, 2 newly built shared hospital, and 330 and the quarantine facility, and 110, that's 1,000 beds, and suddenly and the increase and the support, that's the Wuhan's and that's the healthcare systems. So here's just a science-driven and the target, that's the control strategy, and the designated hospital mainly is for the severe critical and the suspected critical ill patient, but that's also need ICU, need ECMO, and those kind of thing. Fangcang Theater, that's hospital is light, ordinary, but you can look at the gym or the other and the facility, and suddenly and just support, that's the healthcare provisions. But that's the different picture and show those classified treatment and use different kind of facilities. But the other thing I think and the operational resilience, and we should know and calculate how much cost. So actually my team and just calculate those kind of in Wuhan and how much cost and for the Wuhan, that's the healthcare systems. So and publish in Chinese in the Chinese Hospital Administration. But I think that's a kind of a thing is also help for the government and to the healthcare planning, and how to just financing, how to allocate the resources. So I think that's very important. So in that, I think the most of them actually is supporting that's kind of a cost and occupy 85%. So mainly that's kind of other provinces and the medical team and the support Wuhan. And also we do some cost effectiveness analysis and the early stage, and also more cost effectiveness. And that's kind of from economic perspective, and to look at that how to do the cost analysis or planning for health services in the pandemic. Okay, the other is just, I think, similar to other speaker and the prevention, early measure, and we have used a lot of the strategy, but I think timing and just skip those kind of things. And the second, the third part, I would like to talk about the HTA, whether can informing policy making in the pandemic. So that's what HTA is a multidisciplinary process use explicit and scientific robust method to address the value of using health technology at different point, and also comparative, systematic, transparent, and also involve multi-stakeholder and just informing as policymaker and also decision making, and to promote efficient, sustainable, and equitable, and also high quality health system. So we can use HTA, okay, in medical resources allocation, hospital system, and also public health. So here just to show some medical resources and COVID-19, that's the related drug are covered by the basic medical insurance as priority, but that's just a temporary and involving the benefit package. So that's also operation, that's way and how to just include those kind of innovative and specific for pandemic drug included. Also in like vaccination and those kind of things, and use the rapid evaluation, but also including some traditional Chinese medicine. So here is the procedure. I don't want to go through detail, I think, and we also go through those kind of HTA and their procedure to assist. That's reimbursement in China, and that's the temporary included giving priority, and then the medical insurance negotiation, and also cut price for those innovative drug and try to just save and resources, whatever government subsidize or the medical insurance, and that's a sickness fund. Okay, hospital level, and maybe we need expanding the capacity and of public hospital, strengthening hospital management and healthcare human resources, and also building the digital health services. And before the pandemic, I think in China and those kind of virtual hospital is not so get strong support by the government. But after pandemic, I think actually we think that is also very important, and just assisting our traditional that's kind of a hospital and provide services and to our population. Okay, here just a brief summary about HTA, and because I just have 2 minutes, so I just would like to go through the final part and the future thoughts from my perspective. So what kind of a theory can support those kind of operational resilience for our model? Or the other, like, that's the dynamic capacity building, that's kind of model, and whether we have such kind of a model and supporting those kind of resilience. And the other is how to strengthening health system and the resilience. It could be strengthening through many approach, through structure, process, and outcome. I think the structure is very important, like administration structure or healthcare structure, like public and private and tertiary, secondary, and also that's a primary healthcare. But the other, I think, is just the healthcare facility with the research, with company, and how to just make them together. The other is saying the operational resilience maybe is more focused on process. So process need, and everyone, we should work together and try to just solve those kind of resilience and issue. And the other is if resilience, meaning whether health resources as location increasing after those pandemic. A lot of them just healthcare managers think we need and increase our doctor per thousand number or bed, and per thousand the beds, those number. But partly yes, but actually not, because China in the cases just say that mobilization is very important. So maybe, and we say we should and increase a little bit, and just we have such kind of capacity, but more important is just like a mobilization. I think that's also kind of cost effectiveness and way. So by my my thoughts is partly yes, but be careful. And the other is how to measure resilience improvement, mainly performance, effectiveness, but also cost effectiveness. And the final one, and if resilience relevant to NCD, but also our speaker and raised such kind of a issue, I totally agree. I think that's NCD and injury and other challenging and health issue, but also need the resilience and that's kind of just planning and also operation. So that's just my presentation. Thank you very much.
Thank you very much, Professor Chant. Similar to last speaker, do encourage you to formulate the question that you want to ask in the Q&A session. The 4R model is a very good conceptual model. And during the pandemic, operational resilience is not just only to manage the pandemic without any reference to cost. This is another thought as well. But the last question on the NCD. NCD is occurring every day, and even during pandemic, you still have to treat your cancer patient. You still have to treat your emergency patients. And how does operational resilience come into this? So some question for you to think through. Our third speaker is the Professor Dr. Siripan Supakan-Kunti. That's correct, isn't it? Professor Supakan-Kunti is the former director of the Center of Excellence for Health Economics and a professor at the Faculty of Economics, Chulalongkorn University, Bangkok, Thailand. She currently serves as a member of the Asian Network for Health System Strengthening and the cluster of the public-private partnership. Her area of specialized work and interests are specific components of health sector reform, including healthcare financing, health policy, and health service planning. Professor Supakan-Kunti is going to share her country experience on operational level resilience in managing COVID-19 pandemic. Please welcome Professor Supakan-Kunti.
Thank you, and good afternoon, everyone. And I feel honored to be here once again after, well, I cannot remember how many years. The first year that I came here is for the Asian Network for Health System Strengthening network. That is 10 years, more than 10 years ago. And I'm glad to see my old friend and my colleague as well, and the member of the network. And I'm thankful to the Professor EKO for this for today on the knowledge event. We'll be bringing back again to the center. So I would like to share with you for the operational resilience in the COVID-19 pandemic in Thailand. First of all, even though I'm economist, but I'm not going to present to you that with Laksono and the presentation on the health financing. I just would like to share with you on what's happening to Thailand. So how can I move this one? Yeah. Oh, this is different system. In Thailand, we use another term, but anyway, here this is an example for the timeline of COVID-19 situation and response in Thailand. This is just only the first wave. First, when we have the first case to Thailand that we infected with COVID-19, and then that person died some months later, and he died not because of COVID-19, but because of the comorbidity in Thailand. Because of that, caused the person death. So in that you can see in January, the first confirmed case of COVID-19 in Thailand. And that person, the first time that we heard on the first case, that is from Wuhan, right? And that we always follow the news from China by that time. And then the people hope that this pandemic will end within a year. And then the businessman can do that then a normal business later on. But because at the first time, the people follow the with the regulation, the government that just only launched. And then, for example, that work from home or keeping the distance from each other, where your face mask, even though you are in your personal car. Because of that, to prevent person that might sit in the same car may be infected, etc. And so in that time, then you can see that since the COVID-19 started in that Jan and in the 1st March, COVID-19 is officially declared as a dangerous communicable disease. Now Thailand put the word dangerous to make the people just aware of this new emerging infectious disease that we never heard before. We don't know what that kind of the disease, how to combat them, how do the people respond to that. And then in the 12th of March, we established CCSA is like for 1 day after the WHO declared COVID-19 to be a pandemic. And then in the 15th of March, spike of infectious from improved cases in boxing stadium and entertainment venues. This scared the people. Thailand always liked to spend times in the entertainment complex. So the people scared of that disease because more than 200 people have to be quarantined and then check that do they have that the COVID-19 infected or not. And then they have to close for our entertainment complex, for all of the boxing stadium, etc. And then they said, okay, perhaps close for 1 month, 2 months, or 3 months, but actually close more than a year. So that actually hurt to our economic performance system. So in that, how can we really be able to cope with that problem? And that's why 26 March, less than a month, Thailand declared a state of emergency. When we declare a state of emergency, that means government control for all the whole country. And the Prime Minister take an action as a head of all of the government agencies. For the March, we have the first time that, then we have curfew in April, curfew from 10 p.m. to 4 a.m. Meaning no one cannot be out of the house, similar follow with China. And then in the May, but in the 4th of May, it's the first time that we can declare that there is no flu infection reported locally. That you can see that the rate, and then that is the first time. Like in June, in 16th of June, Cabinet endorsed 3 packages to revive ailing tourism. Because tourist industry in Thailand very much is we can call that is in the industrial sector that we can receive more like hard currency from that one. We can export our tourist business. Even right now, Thailand try to promote the tourism once back again. And in June, 29th of June is extended the emergency decree to 31st of July because we found some new cases come back again. And then in June again, educational, institutional resume, meaning during the first from March to June, we close all the school, close all of the university online, like learning. And like in the morning, you have for the Zoom meeting, like in that time, have to thank to that one that Suddenly, we have many ways to communicate to the people far away from home, our friends outside. But believe me, my student told me that they love to learn with me in person in the classroom. They don't like to be learned in the Zoom for all the time because and I have the teacher. I cannot check that the students are actually with me or not. Now to that with we call online. And that's why we resume all the educational institution. And then in the 8th of July, this is the first wave of the COVID-19 outbreak end. And then we have second wave and the third wave later on. And following with that, at the beginning of the many months of the pandemic in Thailand, actually, in Thailand, we achieved universal health coverage in the year 2000, and then outbreak in the year 2019 already. But by that time, NHSO, National Health Security Office of Thailand, has not yet stepped out to fight with this outbreak because that, as I told you, it's a state of emergency. The government take all the power and all the authority. But by after that, the NHSO think that this is the way that they have more cases. Then they start with the what we call is the big data, and then using with the AI. And this is just show you some on the slide data utilization of the COVID-19 dashboard. In that time, you can see that Thailand for the whole country, we have cases in the whole country. And this is to monitor from month to month, and then monitor. And then you can see from that one, how many of the database that correct in one with the NHSO, and then they can start with this dashboard. And this is not to invest for just only for COVID-19. They invest for perhaps in the future, you have a new emerging of the new infectious disease, then you can do similar thing. But Thailand is not a big country, so we can do that dashboard. But for a big country like China, perhaps we had to be at the provincial level. So according to the year 2000, 2 years after the pandemic, Global Security Index report that Thailand ranked number 5 in the world regarding the countries with the strongest health security. And Thailand actually impressive ranking, achieving reflect the country's remarkable resilience and the healthcare development over the past 50 years. And then some challenges remain despite the undeniable benefit of the UC, as I said earlier, and which boosts the affordable cost and robust government backing. So this is the general reference emerging from the national response to the COVID-19 pandemic and its impact on Thailand for the opportunity to strengthen the Thai health system. First, pandemic response reform. You have to look at, heard that you might know on the JEE report, Joint Excellent Evaluation Report. Thailand in the first time in the year 2017. This year, 2023, Thailand is the first country in the world that already complete the second report for the JEE. And right now we are going to use the JEE for the tools, and that it incorporate with the COVID-19. So from that report, say that overall Thailand's coordination mechanism appear very well organized, and it is but administratively complex. So this could lead to the silo thinking. Thailand is very much silo thinking, meaning that each ministry, the cross collaboration across the ministry is very challenged. Then you come to a meeting, but you cannot get any solution from that. So in that is a silo thinking and meeting fatigue among experts involved in several committees and working groups. And second, as you told on the full model, Thailand actually we do follow, but not exactly that, but we do. For example, crisis management. we established the Center for the Administration of the Situation that we call in that earlier that this one is under the Prime Minister Office to strengthen the public health emergency management system through collaborative approach involving all public and private sectors. This is the first time that Thailand, we at the national level, we engage the private sector. We can see more of the private provider step in to this situation. They offer, of course, the government had to provide some fund for them, but they do offer for the health services, try to make the hospital to be able to try to confront with the problem of the COVID-19. One of the private hospital located in Bangkok, they build it's like for the hospital, not permanent, but they build that is just only support for the COVID-19 people. So in that, we can see that public and private collaboration for that one. But after the COVID-19 situation, right now there is not much more of the role of the private sector, and that is the way that we need to do later on. So the issue of a large-scale pandemic beyond the capacity of the system, we do that. We always scared that our health system may not be enough to be able to cope with that situation. So the large-scale management, we call that how to prepare on that. In case of delayed treatment during the pandemic, the hospitals are overloaded and might be a source of patient infection. Therefore, the patient not infected with COVID-19 have a significant impact during that pandemic. So another thing is on academic data and policy decisions, right? Might be different. It is stuck with procedures, legal regulation and government regulation, making it difficult to move. And it is hard to get doctors and nurses to act as lawyers. Patients need something, but they cannot make decisions, and we do not have that regulation, so we need to have the academic data and policy decision. Academic support for medicine and disease control is required, particularly for emerging new diseases and pandemics. And health investment in the past for Thailand are doing reasonable well, but they can not support the situation of emerging diseases, which are fluctuating, uncertain, and enormous. So during the pandemic, comparing the number of patients with COVID and non-COVID and health system capacity, we discussed on the issue of the 4 waves of the pandemic, meaning and the second wave and the third wave, we have non-COVID patients will coming to the hospital, and we found out that actually the number of deaths among all the patients with COVID and non-COVID-19 patients, the non-COVID-19 patients die more. So the work of now, but to tell you that you might hear about our village health volunteer. The work of the village health volunteer has been central to combating COVID-19 in Thailand. The dedication and hard work of our village health volunteers supporting the COVID-19 responses was remarkable and inspiring. Since Thailand has developed policy rapidly, the unexpected response from the Thai people has led to national cooperation. So the Ministry of Public Health and the World Health Organization participated with other of the stakeholders, and they do survey and they do discuss with all stakeholders, and this is including with this issue, country level coordination, planning and monitoring once again, and risk communication and community engagement, and third on civilians, rapid response teams and case investigation. Point of entry and migrant health. You know, Thailand has a very long border with our neighboring country like Myanmar, Laos, and Cambodia. So we have that case COVID-19 along of the border. So Thailand had to prepare for that. And national laboratory systems, infection prevention and control in community and healthcare facility, on clinical management and operational support and logistics in supply chain and workforce management, and maintaining essential services during the COVID-19 outbreak. So in conclusion, this requires policy commitment across successive government, because Thailand, you might hear that we change government so often. Not every 4 years we have a new government. Sometimes we have 1 year we have a new government, 2 years we have a new government. But we're hoping that later on in the future we will have 4-year government. But when we have the government, the successive government should follow is like this: adequate number of committed and competent health workforce at all levels, support by over 1 million of village health volunteers. Before village health volunteers do not have any of the, I could not say it's a salary, it's not, but some per diem, not much, some 100 baht only. Nowadays, 35 baht per $1. The government, the Ministry of Public Health, in that time, minister, they promised that they are going to provide some money for all millions of village health volunteers for like 2,000 baht per month. After COVID-19 finished some year, they just receive only 1,000 baht per month, and not sure that they will continue to receive it or not because we changed the government. And second, substantial social capital and community resilience. And third, changing from a free market and technology driven to a sustainability-driven concept. This is because during the pandemic, even though we engage the private sector to provide services, but somehow, sometimes the price occur in the private sector is not reasonable, meaning it's quite high. And then that we need to do technology driven. And four, continue accelerating the implementation of laws and regulation defined in Communicable Disease Act in Thailand 2015 for disease control at both domestic and international levels, and stimulating the full implementation of the IHR, International Health Regulation, sharing all the information for health security policy. And this is our village health volunteer, right? To support the primary healthcare system, a national program of over 1 million village health volunteers for many years had collected data, maintained health record, and educated the community on how to prevent communicable and non-communicable diseases. During COVID-19, as I said earlier, that they contributed Thailand's early warning system and supported surveillance, detection, contact tracing, and health monitoring. As I said earlier, that they do not have authority. They cannot prohibit anyone to not to be out of their house because they be infected with COVID-19. They need the policeman to help them, to work with them. And consider supporting the budget and human resources regarding the amount, technical skill, and quality, strengthening international cooperation, especially local capacities to develop and produce the pandemic response products and vaccines through actual technology transfer. Talking about the vaccine, long before Thailand has strategic plan to build the capacity to produce the vaccine at national level, but never be done because of COVID-19. Suddenly, we have the national vaccine production at national level. And six, defining duties and job responsibility of our agency, because as I said earlier, it's silo making for Thai government agency. And engaging the private sector and communities as key stakeholders in preventing, detecting, and responding to all events and disease control. and role of medical and health professional schools to strengthening the primary care healthcare system and producing quality and committed health professional care workers and supporting their career development. And I think that this review was limited to the public health aspect of Thailand, and I have very few minutes to present. But I think that from the result of the finding may helpful to other countries as well. And this is just only photo for Thailand. And welcome to Thailand once again after the COVID-19. Thank you.
Thank you very much, Sylvan. Please take a seat. Can I invite Professor Chant and Laksono to come out and take a seat here, please? We're now coming to the Q&A session, which I think is the most exciting part of the session, because this is your time to interact with our speakers, the three distinguished speakers. And we have heard through their presentation that pandemic is actually a very dynamic process, changing from time to time. And if you remember this morning's Professor Ikeyo's presentation, he defined resilience as our ability to anticipate, to plan, to prepare, and to get ready to respond to the hazard. And the hazard in this case is the COVID-19 virus. So from the anticipation and the planning part, the early warning system that Siripan mentioned is very important. So I saw a hand. You have got a question, madam? Yes? Yeah, please wait. Yeah, please indicate to me, yeah, if you have question, and yeah. And we pass the mic to you, please.
Thank you for the opportunity. Let me introduce myself. My name is Yunita. I'm from Indonesia. Actually, I'm from Association of Public Health Center in Indonesia. But actively, I'm now working in Health Department of Jakarta Province. Before, I want to ask for maybe for the three speakers. First, for Laksono also. Actually, we are in the same team together to come here to get our calls. It's really interesting. Of course, Prof. Laksono is talking about economy, but I want to ask more about actually for health economy, especially it is not only responsibility for our health department, especially Minister of Health. Yeah, I think we have like Minister of Finance or any other like internal affairs. Maybe we have to make more collaboration with other parties. So not only health department, because if we just consider that it is only responsibility for health industry, I think that's why COVID-19 cannot be helped very well, especially in Indonesia. I need your opinion about that. And also, of course, of the three speakers from China and also Thailand. And we, of course, have learned very much from Thailand that is really successful. And from the graphic, we can see that's really easy for Thailand to compare with COVID-19. But I think is it influenced by the government system, I think. Because in Indonesia, we have republic like same like China, and the people in Indonesia is very diverse, yeah, for Laksono. Sometimes like in Jakarta, they are well educated, but in rural area, because we have many islands, sometimes people cannot be touched very well. If we ask them to get vaccination, they cannot be easy to get vaccinated. And I think it's happened with Thailand. Maybe they really good, yeah. What the government say, you must get vaccinated, so they will, okay, I will get vaccinated today. But in Indonesia, it needs 3 times or even 10 times to tell people to get vaccination. That's my questions. Thank you very much.
Thank you. Yeah. So the question is, fighting pandemic is more than just the health ministry. Laksono.
Yes, I will Additionally, Ministry of Finance is the strongest minister in the cabinet. Yes. But during the COVID, the second position is Minister of Health, because people understand very well that if the COVID-19 pandemic becoming prolonged, we can see that the Indonesian GDP reduced by 3%, and all of government revenue also decreased. So economic problems, and when the economic problems becoming worse and worse, that's become political instability. So that's why it's not a good idea, because COVID-19, Ministry of Health becoming very important ministry. Okay, at the COVID time. Okay, but how about after the pandemic? That is the most important issue, that we have to make sure everybody that health is not like ordinary program. Health program is also investment for the economic activity. That is very important. Without any health programs, and if we don't have enough healthy people, then our economy will be suffer from what we call like lacking behind the other countries. Okay, so health is investment for everybody. Is the point.
You know, any comment from you on this, and then Sylvan?
Okay, thank you. I think that's a very, we should, I think similar, that's invest in health, and also have a lot of like social, and also that's kind of outcomes. So I think, and then because from health economic, we just measure those kind of medical costs, but we also think about how about the productivities, and also intangible, those kind of well-being or others. So we maybe, and we try to just balance those kind of things and together, but that's economic and the perspective. Yeah, very briefly.
Sylvan?
Okay, thank you. I'm health economist, and as Professor Laksono said, we always say that health is actually the one very important in terms of the human capital. So when we invest in health, we produce the human, we call human development. So in that, how much return? But the return on human development or investment is not a short-term benefit, it's a long-term benefit. In case of COVID-19 for Thailand, because Thailand is not, but it's not island country. So Thailand it's like, you can call it's like quite homogeneous country. We can have some regional different, but it's not very much. Have in that sense, we speak the same language. So in that time, the government declared state of emergency. That is very important for Thailand, because all the authorities is to the Prime Minister. So in that time, the Minister can call from the Ministry of Health, Ministry of Finance, Ministry of Commerce, and etc. to what should be the best way for Thailand from now on to combat with the disease. In that time, at the beginning, as I said, people scared of that new disease because of they want to protect their family, so they follow for all the regulation. But it's not for a second or for the second year or third year. It's quite challenge for the government. But somehow in that time, the Bank of Thailand, they already announced many of the monetary policy, many of the tax reduction measures for the businessman, and even for some of the family as well. In that time, there are many of the measures that be ongoing announcement following the COVID-19. And of course, many they anticipate after the COVID-19, what happened to the economic performance of the country. And we realized that it did. And that's why now we think that for the government, any of the investment of the policy must have health impact assessment, not only environmental impact assessment. They must have HIA, not only EIA, and that is ongoing.
I see another perspective from your question. In the cabinet level, health is always the minor partner, whereas finance and commerce and industry are the major partners. That's what your question is implying. So if you want to turn this into a major decision part of the government, then you do need leadership from the very top. I like what Selamat said in her presentation, talking about the vaccine production in Thailand. They have turned this pandemic, the crisis, into an opportunity. And in crisis in our Chinese language has two words. The first is danger. The second is opportunity. So turning leadership is to turn the crisis into an opportunity. If you have got good leader, able to see how the pandemic is actually causing harm to the well-being and the wealth of the individual as well as the country, then automatically it will become the top agenda. Yeah. Professor Ikeo?
Thank you very much for the very interesting presentations and different perspectives in terms of how to look at the resilience. But I want to cover to Professor Laksono and maybe Siripan and Professor Chant can comment about the decision making. I think one of the issues in the pandemic is decision making is quite imprecise. Right? And I think Professor Laksono talked about in Indonesia the transdisciplinary approaches. I think it's certainly very important. I was quite interested to know about the political science, the social sciences, and the behavioral sciences approach, because in that judgment, the imprecision itself can cause the problems with the system. The system can be overwhelmed. So you can either be too late, or you overdo it, right? So in Hong Kong, we had this issue about in terms of decisions that all patients had to be treated in hospitals, irrespective of whether it's symptoms or not. Of course, that overwhelmed the system. So when you make decisions like that, it's really the basis of that decision. Because there's also the element of the political science there. Because I think if you don't know what's going to happen, the policymakers might err on the safety precaution, right? So you tend to err on it, because if you make the wrong decision, then it comes back to haunt you later on. So I was just very interested in how decision making was done in Indonesia with the political scientists, and then what was considered in the context. Because we also looked at the risk assessment mechanisms, because you cannot have just one. You cannot quantify it by medical terms, right? But because you need to have a different facets of decision, a basket of things that you look from the economy, the political side, the health side, because you can't quantify it all into one figure in terms of health.
Yes, okay. I think this is the answer about how the policy making and the decision is done in Indonesia. This is the things that it is very amazing that actually the process of making the decision, because I was at that time the meetings, hundreds of meetings. It's not only from epidemiological perspective, not only from the medical science, say for the lockdown decision. In Wuhan, you have very, very strong, very strict lockdown. And at the time, in Indonesia also, there's a heated debate whether we have to look at China experience to very tight lockdown or not. Okay, so the point is, that's why I said in my presentation, I don't understand at the end of the day about the decision, but at the end of the day, we decided not to copy or to use the Chinese experiment for having a very, very strict lockdown. And this take risk as well. So this is the things that I urge you, Prof. Ike, and other scientists. Let's go to the what is so-called transdiscipline policymaking. It is the amalgamation of the so many sciences, okay? But I realized that there is some like an art, like an instinct to make decision, and it is so difficult to describe in terms of scientific sentences. Yes, maybe we can ask about the
people that make decisions are not scientists.
Yes, I agree with you. Yeah, but they are surrounded by hundreds of scientists, but in many disciplines. But at the end of the day, they have to make a decision. Okay.
Or indecision, as in the United Kingdom, we are hearing from the inquiry what decision that have not been made. Yeah. Please.
Thank you. Thank you, experts. I am Suel Huang from Center for Asia Pacific Resilience and Innovation, a public policy think tank set up in Taipei. And I'm also wondering, different experts also mentioned the need and the challenge of incorporate different disciplines, different experts' opinions into decision making. And at operational level, I think one thing that I identified across different countries and in today's sharing among experts is that sometimes new institutions or new working groups have been set up to respond to crisis, especially in public health. But I'm wondering what kind of legacy we can preserve or we should keep after these waves of pandemic to make this interdisciplinary decision making or interdisciplinary public policy analyze, making it a norm and then better prepare for the next pandemic. Do you have this kind of institutional setup in your country respectively, or do we need to push for that in prepare for the next pandemic? Thank you.
Okay, Sarah, do you want to take that and then we know?
It is very challenging, actually. Let I say, for example, during COVID-19, when the government want to lock down, not the whole province, lock down community, for example, we can lock down community level only, but not the whole province. Or lock down some of the entertainment complex, boxing stadium, and even with the factory that they have to manage all the labors. In that time, when they are going to continue, because they say that, okay, you can open your business, and later because of some new cases emerge, and they said, oh, you cannot. Just delay the open of their business. Then delay for many years. Then for what happened? The government always said, this is recommendation from the scientists, recommendation from medical doctor, the expert, the national level is expert. Then the people had to believe in that person. And later, but Ministry of Public Health, or even that person never say any word to support or locking their business. You know what? Because who's take responsibility for that, the following of that crisis? And so if you look at in the journal, how many actually the paper had addressed, this is the epidemiologists finding and then lead to the policy making. I feel very few, not many. They are in the epidemiological journal only, and not on the social science journal. That's why, because of when the scientists doing their research, they always said they are already to look at the actual finding, actual number, etc. But social scientists always said, with this assumption, assume people are rational, for example, then that will be followed. So I think that the discipline is quite different in that as a basis. Look, however, after the COVID-19, what will happen? If the scientists still keeping their work and look at that for the whole country, for the general population, and address how important of their finding of that information, and I think that the decision maker somehow, again, not wait through the epidemic, they have to listen. As I said to you, that Thailand now with the HIA, health technology, the health impact assessment had to be done, not just only the environmental impact assessment.
Okay, thank you.
I think in China, actually, those kind of policy making and also, that depends on that's the academic support. So that's in the previous 3 or 4 years, I think a lot of our faculty actually working for the local Shanghai government and also the central government, and they provide a lot of modeling and estimation and also just kind of forecasting. But maybe the challenge is, so that's our system is so comprehensive, so many, and that's the indicators and those kind of things. So a lot of models there, but policy maker or politician will ask, what is the real one? What will be happen? So that's kind of uncertainty, how to just solve the uncertainty. So that's kind of, if in Shanghai, we have Fudan and Shanghai Jiaotong, maybe they have different opinions, different model, different result. How to just look at those kind of different models and the result. But I think that's the first. So if today, that's kind of evaluation. The other is appraisal by the policymaker. So how to just making decision, so many other factors, maybe not included in the model. So that's, I think is challenging. And I think it's just try to solve the uncertainty of our modeling or forecasting. Spend a lot of academic and works, but also I think is also those kind of academic work, how to translate it to just confirm that's kind of policy making suggestion sometimes, and there's still a lot of way to go.
Perfect answer to a very important question. Thank you so much being a very resilient audience to us. And let's join in to thank our 3 distinguished speakers. Thank you very much. Thank you.
Thank you again, Dr. Low and our presenters for a very engaging session. It is now time for a short break before we move on to our last plenary session of the day. There are going to be drinks and snacks again in the foyer. Please enjoy. And we'll reconvene back here at 3:45. Thank you.
Okay, 1, 2, 3. Okay, thank you. Thank you very much. Thank you. It's really WHO. Yeah, WHO, yeah, maybe. But maybe WHO passport. No, you have to post that in sure. No, today in the yeah. It's always good at the health. Yeah. My partner, Professor Chung-mau. We were there for 2-3 days with the meeting.
吴老师的一起，
collaborating. No. That's the reason we also post that for but in that some years ago, many years ago. But I think maybe I saw yeah, I know you, but yeah.
有声音是没看到。
Okay, yeah. Thank you. Please keep me. Sorry, I go back.
或者是你给我一个 U 盘。 可以。應該我擺咗喺呢度嘅，你裝呢個第一個。 你做下，睇下係咪呢個？
應該係。
啊，係啊，應該係啊。
改咗嘅。
Total 係咪15張？
加埋個封面12啱。
OK， 呢個啱嘅，啱嘅。
聽，唔該晒。咁我個講詞放喺呢度啦。放喺呢度啦。都係打緊先講，唔係打緊。
我知咪瞄咗。
呢個係 Kerry。
係。得。我呢度刪咗佢先。可以。因為佢抄過嚟。聲拉過嚟。
咧就係撳下嗰個，
係或者你撳呢個
呢個唔好啦，呢個轉咧，
撳
咁 sensitive 嘅，好容易一去咗幾張一去咗，
右最好，
右最好啊！
嗱，而家
右係咪即係下？
邊個拋啊？
第一個
嗱 full screen 啦
，full screen 啦，
再 full screen 就呢個嗱，跟住你右啊，
哦係喎係
喎，最方便，係喎，會撳錯啊嘛
，OK，唔該晒。
唔係先。
Do you need to check? Is it your? Sorry, you just go ahead.我想睇下我，都望到，睇下要唔要轉老花鏡咧？都望到。OK 啊，係唔使，唔該晒。晾高佢好少少，唔使我個頭耷得唔低。
Thank you very much, Nancy. So, welcome to the fourth plenary sessions on community resilience, and we're very happy to have speakers from across East Asia to share with us their experiences on building community capacity during the pandemic. So, without further ado, I would like to invite Ms. Ada Chung from the Privacy Commission for Personal Data to share with us her experience of Hong Kong during the pandemic. So before her appointment as the Privacy Commissioner for Personal Data, Ms. Chung was the Registrar of Companies, Registrars of Moneylenders, and held various posts in the Department of Justice. And Ms. Chung has acted as the legal advisor to the government in various inquiries relating to the outbreak and spread of SARS in Hong Kong before too. So using the case studies of a contact tracing app, Leave Home Safe, and the vaccine passport in Hong Kong, Ms. Chung will share her experience with us on protecting data privacy and building trust in the community of Hong Kong. Thank you, Ms. Chung.
Thank you, Dr. Lai, for the kind introduction. Dr. Lai, fellow panelists, distinguished guests, ladies and gentlemen, good afternoon. First of all, I would like to thank the organizers for having me today. As mentioned by other speakers at the conference today, the COVID-19 pandemic has brought huge challenges to us all. As a privacy regulator, I've encountered various privacy issues brought about by the government authorities' response to combat the pandemic. And I would like to share with you today some of my observations and thoughts on the need to protect privacy while safeguarding public health in a way that builds trust and community resilience. To begin with, I would like to refer you to two surveys conducted by my office on behalf of the Global Privacy Assembly, which is an international assembly of data protection and privacy authorities. The two surveys, which were conducted in 2020 and 2021, explored pressing data protection and privacy issues which arose during the pandemic. And we collected returns from different jurisdictions on the relevant experience and best practices in different jurisdictions in their dealing with privacy issues. The survey results were contained in two parts of a compendium compiled by my office, which were produced with a view to providing a handy reference to all on the best practices adopted in other jurisdictions to safeguard privacy while adopting measures to combat the pandemic. And the topics covered in the compendiums include, for example, contact tracing, health passports, e-learning, work from home arrangements, and more. And today I'll be focusing on health passports and contact tracing apps. In both surveys, both for the one conducted in 2020 and for the one conducted in 2021, there were 33 members and observers of the Global Privacy Assembly who responded to the survey. And from this slide, you will see that most of the responses came from Europe, which is the green part in the charts, followed by Asia and North America. Preference of contact tracing apps. Both surveys looked into the prevalence of contact tracing apps in different jurisdictions. And I've shown the more recent statistics from the 2021 survey here. The survey shows that
Around 66% of the jurisdictions covered by the survey, namely 21 out of 32 jurisdictions, which is shown in green on the pie chart on the left, they have adopted mobile applications for contact tracing purposes. And with about a quarter of the jurisdictions surveyed having no contact tracing app at all, and it is covered by the blue part. And among the 21 jurisdictions with contact tracing apps, 18 of them adopted a decentralized approach, meaning that the data collected by the contact tracing apps were kept, processed, and stored in the mobile devices of the users, namely the mobile phones, and with only 3 jurisdictions adopting centralized or other approaches. In the 2020 survey, in the earlier survey, we also looked into jurisdictions' use of location tracking. And perhaps not surprisingly, we found that 75% of the jurisdictions surveyed did not have the location tracking function in their contact tracing apps. And apparently, this has been done to address privacy concerns in the respective jurisdictions. Major privacy risks of contact tracing measures. I've set out on this slide some of the major privacy risks identified by the data protection authorities. They include, for example, risks relating to data security, the use of Bluetooth signals, re-identification of users, excessive collection of personal data, excessive processing, disclosure, or use for secondary purposes. Regarding the excessive use of or the disclosure of personal data, I believe that some of you will remember that in Singapore, for example, there was a public outcry against the contact tracing app, the Trace Together in Singapore, when it was reported that the police actually had access to the data collected by the contact tracing app. And this has led to a backlash at the time in the community and undermined the credibility of the health control measure. I remember that at that time, the then minister in charge of the implementation of Trace Together, Dr. Vivian, did have a very difficult time in the parliament when he was bombarded with very difficult questions. And this has subsequently led the government to amend the law to restrict the use of data collected by the Trace Together for public health purposes and also for the investigation of 7 more serious crimes. Let me now turn to the situation in Hong Kong. In Hong Kong, we do have a contact tracing app, which we call the Leave Home Safe app. The Leave Home Safe app was first launched in November 2020, about 3 years ago. The use of the app was voluntary at the beginning, and subsequently it became mandatory for the purposes of entry to certain specified premises, such as public markets, public libraries, restaurants, and bars. At that time, all citizens in Hong Kong, unless they were exempted because of age, for example, if they were minors or if they were elderly, they were exempted. Otherwise, citizens were required to use the app to scan the QR codes displayed at the entrance of premises before they were allowed to enter the premises. And in scanning, by scanning the app against the QR code, visit records were created and they were stored on the user's mobile phones. The app would then regularly download the visit records of confirmed or suspected cases from the Center for Health Protection. And the records would be matched against the visitor's own visit records in the user's own mobile phones. Essentially, we have adopted a decentralized approach. And if users visited a premises that a confirmed patient have visited at or about the same time, they will receive notices of risk exposure and also compulsory testing notice. The app was used for about 2 years in Hong Kong. and it ceased operation in January this year, following the relaxation of different kinds of anti-epidemic measures on the resumption of normalcy. As Hong Kong citizens are quite concerned about invasion to their privacy, the introduction of the Leave Home Safe app at the time did raise a lot of questions and discussions in Hong Kong. There were so many questions raised that at one stage I have to issue a media statement saying that the app has no location tracking function and it complied with all relevant requirements of our privacy law. Good privacy practices adopted in the Leave Home Safe app. Actually, I would say that the government took pains to incorporate quite a number of good privacy practices in the Leave Home Safe app in order to reassure the public that their privacy is properly respected and protected, notwithstanding the introduction of this contact tracing measure. For example, to minimize data collection, the app did not collect any location data. Neither did it require any registration before users can download the app. And to minimize data uploaded, visit records were kept in a decentralized form on the user's mobile phones. They were stored on the user's mobile phones and they will only be uploaded for confirmed cases for contact tracing purposes. And it was only in the event of a confirmed infection would the user's visit records be uploaded for conducting contact tracing. And in terms of data security and retention, visit records were encrypted and they would be automatically erased after 31 days. In terms of purpose limitation, all visit records updated were deleted when the operation ceased, when the app ceased operation in January this year. Actually, the government made a public announcement when the app ceased operation in January this year in order to reassure the public that all visit records were deleted, and so the government did not keep any records, and therefore there was no government surveillance in carrying out all these contact tracing actions. And in sum, I would say that the government did make huge efforts to address and mitigate privacy concerns when it introduced the contact tracing app. So much for contact tracing apps. Now let us turn to look at health passports. Prevalence of health passports. From the surveys that we have conducted in 2021, we found that health passports were commonly used in many jurisdictions surveyed by us, either for facilitating cross-border or cross-boundary travels, or for facilitating domestic activities. Similar to the situation of contact tracing apps, a number of major privacy risks of health passports were identified by the data protection authorities. And perhaps other than false health passports, many of them were looks very similar to those which I've mentioned before. And they relate to, for example, security risks, unnecessarily displaying or sharing personal data. That means unnecessarily disclosing personal data, excessive personal data. And personal data was retained for longer than is necessary. It was reused for secondary purposes without any authorization. Back to the situation in Hong Kong, health passport, or what we call the vaccine pass arrangement, was introduced in February last year, mainly as a means to boost vaccination and also as a means to facilitate domestic activities. As the Director of Health, Dr. Ronald mentioned this morning, he said that after the introduction of the vaccine pass, actually the vaccination rate in Hong Kong increased quite a lot. And why did this happen? It was because at the time, citizens in Hong Kong were required to be vaccinated before they were allowed entry to certain types of premises, including public places, shopping malls, restaurants, and bars. So even if they want to go to have dim sum, they will need to get vaccination first before they can enter the restaurant. And vaccination records in paper or electronic form affixed with a unique QR code indicating the vaccination status were required to be presented to the operators of specified premises. The operators would then use a QR code verification scanner to scan the QR codes affixed on the vaccination records for verification purposes. And for the confirmed cases, the QR codes will be shown in red, and the infected persons will be restricted from entering the specified premises. Actually, the vaccine pass arrangement was implemented for almost a year, at a time when there was much discussion in Hong Kong about the zero COVID, or rather the dynamic zero COVID policy. The requirement was finally removed in December last year. Again, similar to the situation of contact tracing apps, a number of good privacy practices was adopted in the vaccine pass arrangement. As most of the measures were similar to those of Leave Home Safe, I just want to highlight a few here. To minimize the disclosure and uploading of data, only a QR code and vaccination status were required to be presented to the premises operators. And actually, no personally identifiable information will be shown to the premises operators. In other words, only QR codes were shown. No personal data was given to the premises operators. And although the visit records were kept on the operators' apps, they were kept in an encrypted form, and all personal data were hashed and masked. In other words, although the operators of the premises kept the visit records, they did not contain any personal data. And it was only if a confirmed patient had visited the premises would the visit records be uploaded to the government server for conducting contact tracing. In other words, the government took pains to incorporate all these privacy by design features in the design of the health passport in order to reassure the public that they still hold their personal data themselves, and the personal data at no time was given to the operators of the specified premises. It was only in the case of a confirmed patient would the record be uploaded to the government server for re-identification of the patient in question. Looking ahead, when the next public health threat emerges, I believe that novel technological solutions would emerge, bringing with them new privacy risks. And I think the essential question, which has been the theme for discussion today, is how could we apply the lessons learned from this pandemic to safeguard public health when the next crisis strikes, while safeguarding and addressing the privacy risks involved. In fact, from both surveys conducted by my office, we found that the best practices recommended by different data protection authorities regarding contact tracing apps and health passports have many similarities, and many were in line with or were derived from conventional data protection principles, such as data minimization, limitation of use, limitation of retention, etc. And I believe that going forward, conventional data protection principles are still applicable in future crises in striking a reasonable balance between privacy protection and safeguarding public health. To complete the picture, I've set out some examples of the best practices recommended by the data protection authorities worldwide in this slide and in the following slide. Indeed, you will see that the recommendations are premised on conventional data protection principles such as data minimization, strengthening data security, purpose limitation, being transparent in the process, and adherence to the principle of privacy by design. And with that, I've come to the end of my presentation. Thank you very much.
Ms. Chung, I do remember the time that when I need to, every one of us need to get our phone out, and if we forgot our phone at home, we can't use the Refund Safe app and vaccine passport, so we always need to rush home and get our phones back. So those were the days. Okay, thank you very much again. Now I would like to invite Professor Hirara to share with us her experience in the Philippines. Professor Hirara primary interest in business consulting, and in the public sector, she provides advice in the areas of health policy, health finance, and financial services. She is also a contributing author of several books covering the areas of leadership, strategy, risk management, corporate responsibility, and her current areas of research includes innovation in global value chains, corporate social innovations, youth leaders for social change, health finance and health policy, and governance of conglomerates and family corporations. So drawing from her experience in the Philippines, she's going to share with us on the use of data analytics and practical community approach to strengthen community resilience in future pandemic. Thank you very much.
Thank you. I guess first of all, I want to thank Professor Ikeyo for inviting me back to CUHK. And I want to thank all of the previous speakers that came before me. I'm actually really sad that our Secretary of Health was not able to join us because I was counting on him having paved the road for my presentation. Last year, before Secretary Duque, the previous Secretary of Health, handed over responsibility for the department, he said this, that the Department of Health has always been aware that the COVID-19 pandemic response is more marathon than sprint. We are carefully pacing ourselves using the whole of government and whole of nation approach led by President Rodrigo Roa Duterte. As the current administration ends, we are confident that the next administration and its incoming Secretary of Health will continue, even improve our march to recovery in the new normal. I wanted to start with this because I think what has become apparent over the entire day is that the COVID response was never going to be a one-off. It was never going to be 3 months or 4 months. And in fact, as everyone has been saying, to this day, we are still looking at what things we learned and what we should apply for the future. So I want to go back. I guess for you to understand where I'm coming from, I'm primarily a business person. I was trained as an actuary. So I tend to think very micro, business level. When the National Health Insurance Law was being drafted in the Philippines, 28 years ago, I'm so old, I was drafted into health policy because none of the people advising government understood insurance. They understood economics, they understood health, but I had no idea what insurance was. So I said, I can teach you insurance, but I know nothing about policy. And they said, we'll teach you policy, you teach us insurance, we'll get this done. Okay. And that's also how I got dragged into the COVID-19 response. A lot of people were asking Mayas what's happening. So I called the Department of Health and I said, do you have any information that I can use? Because all I have is international data. This is very early days. And they told me, oh ma'am, we're so happy you called. We need you to calculate something for us. So the very early days, we were late to the pandemic. In February 25, we had 0 local cases. Actually, we relate to a lot of pandemics. We completely skipped SARS. If you look at the map of Southeast Asia during the SARS pandemic, the Philippines did not exist. We had no cases. Okay, so this was, I think, our very first major pandemic, at least in the last 20 years. On January 30, we had our first COVID-19 case. It was a tourist. February 1, that case, we had our first COVID-19 death. On March 11, we had our second death, and that was a confirmed local transmission. The next day, the Philippines declared code red sublevel 2. And we announced class and work suspension and community quarantine to begin on 15 March. Community quarantine is a word for lockdown. Okay? On 16 March, enhanced community quarantine was raised in all of Luzon. At the time, there's a lot of furor because they were like single case in one area. Why is it the entire island of Luzon? And the answer to this was, this is a contiguous area. We did not have the personnel to try and figure out how people were moving from one area to the other. Okay, so what were the key aspects of the early data analytic work? We looked at epidemic trajectory analysis and forecasting, so analysis of social contacts, review of literature, and review of scant local data. The early data analytic work really pointed to the first lockdown that was announced was 2 weeks. 1 week into the lockdown, the question was, what happens a week from now? If we keep everyone in their houses for 2 weeks and then everything goes back to normal, clearly that was not an option. But how do you explain this to decision makers? How do you explain this to businesses? How do you explain it to the employees who, if they don't work, don't get paid? And therefore, how are they eating? We needed to inventory available health capacity. We needed to estimate health logistics requirements. This was actually my very first assignment. Ma'am, how many ventilators do we need? That was, I think, very early on. We needed to figure out how many ventilators we needed to buy for the country. We needed to evaluate economic impact and funding requirements, both direct and indirect. So direct was things like buying ventilators, etc. But there were a lot of other things, communication. It was also a lot of how are you feeding the people who aren't getting paid? Right? Throughout the entire early days of the pandemic, it was always the economics versus the health. And which was why it was always the Department of Trade and Industry versus the Department of Health in the beginning. We needed to find a way to get people to agree. How? So that very first, the first 2 weeks of the quarantine, we actually, the scientists knew, those of us who were running the numbers, we knew that what we wanted to be able to show was if we do a certain thing, what does that mean in terms of where the pandemic goes? How many more new cases, how many potential deaths? Versus if we do this, how many more new cases, how many more potential deaths? But we needed to do it in a way that would convince the policymakers that it made sense. Not just that would convince the policymakers, that would convince them enough that they would be able to go out to business, go out to the public, and be able to defend their decision. I was heading one of the teams that was doing this. When I made my presentation, I found that there were 3 teams that the government asked to run the calculations, which actually made sense. Because once 3 entire academic teams showed the government, these are our presentations, and we all agreed. We didn't talk to each other. We all had the same conclusions. Essentially, the policymaker said, okay, we believe you. Okay. I don't know how much you know about the Philippines because Secretary Bosa was not here today. The Philippine pandemic response was headed by an interagency task force. Like every other country in the world, we had all the agencies of the country were represented in the task force. The chairman was the Secretary of Health. Okay, so we prepared this essentially for the sub-technical working group on data analytics. I'm not going to go through this model. Sufficient for you to believe that we ran a mathematical model. I actually had to explain this to politicians. Okay, so we have to explain it this way. And the previous slide confuzzled them. This they got, because this was just where the numbers will go. So we showed cumulative deaths, cumulative recoveries, infections, new infections, hospitalization. Hospitalization was important because we could tell them once hospitalization requirements reach a certain number, we're in trouble because we only have this many hospital beds. We only have this many ICUs. I think about 2 weeks after this, we were already at the point where we could predict how many ventilators we were going to need at every level. Okay. So all 3 teams told the government, if we lift the quarantine, the end of 2 weeks, as we originally scheduled, with only moderate interventions, there will be a very quick ramp up. I mean, why did we do it at all? Our scenario 2, 1 month extension. Moderate post ECQ. So moderate post ECQ, no extension. 1 month extension with moderate post ECQ extension substantially flattens the curve for the year, which is all. But then it begins to rise again, but it buys us time. That's actually, this was our first message. We need time. We need time to buy more ventilators, to bring in more hospital beds, to create the quarantine facilities. We need time. We also needed time for the science to develop. In the very early days, remember March 2020, we didn't have a lot of data. We had, I don't know what, less than 100 available papers. So we basically said what we need actually is heightened post-quarantine efforts. Okay? And that included mandatory masking. And I remember one of the most important questions was, where can we get the masks? There are not even enough factories making masks. So one of the things that our Department of Trade and Industry actually started doing was going around talking to factories, asking them to convert to mask making. So when I talk about practical approaches, when we operationalize a response, it can't be just the science. You actually have to find out, can we operationalize this? What will it take? What is the economic cost? And that is why it was always health and economics. And it wasn't just the economic cost, it was also, how do we get business into this? So essentially what we did, it was extended. The thing about being able to explain to government, not just the numbers, but why and what is required, is that they had the story. The clear story of what they needed to tell the public. And not only that, they also had the clear story, not just of the why, but of what needs to be done, what they can do, the public, the business sector, and what would be the effect on them if they did it or they didn't. So that clear storyline gave us a path forward together. Okay. And I think it really didn't help that 3 entirely different organizations presented essentially the same recommendation. Okay, so what are early lessons from this? Data is just the beginning. The science is really tough when the data is still developing, especially in the early days, but we must still make decisions based on the science. Response implementation is challenging in an environment of scarce resources. As I said, one example, mask availability. The supply chain still need to keep flowing. So one of the most important things we needed to do is how do we make sure that food continues to flow to the correct households, that we still have transportation for essential services, everything. So that identification of what's priority and what exactly is an essential industry needed to be done and quickly. The definition of community can be very fluid. We can just say because you are a city, that is the same, that's how we're treating you. Because if you're a city with 3 other cities near you, and everyone that works to, for example, Makati is a business district, about 70% of the daytime population of Makati comes from other cities. So contiguous borders make definition of communities pretty fluid. Remote communities are very different. Also, when you think of communities, we can't just think of political communities. A large business with 5,000 employees, that is its own community. An association is its own community. And I say this because when I think of community resilience, I just don't think of protecting a community, but also how do the different communities help us when we respond to a pandemic. Right? So professional associations, even alumni groups, homeowners associations, they were very, very important in the COVID response. We realized that communication is key to cooperation. One of the most controversial of the decisions of the Philippines was to have mandatory face shielding. We were one of the, I don't know how many countries actually made face shields mandatory. We were one of the very few countries that had mandatory masking and mandatory face shields. This was extremely controversial, but our government policymakers basically said yes. And the reason for that was we showed them the numbers. We said masking only, masking and shield this. And we said, we think it makes sense, but here's the percentage. Let's multiply that by 110 million Filipinos. Okay, times the number of people you're going to let go to work. What do you think about that? And they said, okay, we're going to do it. But communication was key to that. Being able to show the numbers was key to that. It's important to harness all resources, all levels and branches of government. So it wasn't just interagency, it was also at every level. The Philippines is a devolved governance country. So we have national, we have regional, we have province, we have city, we have town. Below city and town, we have barangays, which is what we call the villages. Okay. The COVID response, businesses were very important, foundations, NGOs, aid organizations, formal as well as loose organizations. And I think the last lesson I wanted to put in was it's important to encourage innovation and initiative. When we looked at supply chains and we looked at how do we get the food to people, but we want them to stay home. So the innovations of many local governments was to have mobile markets, actual traveling markets in jeepneys. Okay. Oops, sorry. Okay. But health is not the only relevant lens. So the other thing that we were doing, that I was personally doing, that a lot of people were doing, was providing support for entrepreneurs and business, because the money still needs to flow. Okay. And as we all know, the economic effects can be severe and recovery can be very tough. At the heart of all of this, you know, that effective response requires effective communication. And I think that's one of the things I wanted to say today, was credibility is critical to effective communication. A large part of what the national response in the Philippines was grounded on was the science. Okay. We had the ability to show the numbers, not just nationally, but regionally, by city. We fortunately already had a platform that we were using for dengue, measles, and I think polio, that was quickly converted to a platform for COVID. And we provided it to local governments. It had a dashboard. They were able to cut within their own municipalities. So up to the barangay level, in our barangay, up to the street level. For every street, we knew how many confirmed cases, how many households. We were able to show them at the local level, health capacity numbers, security index, socioeconomic numbers, healthcare statistics, time series projections. We put the time series projections ability in the hands of local government executives as well as analysts. We could model policy decisions. And I think one of the messages we wanted to say was you can't be afraid to expose the public to the science and the math. We actually showed some of these graphs when we were talking to the public. And modeling potential, EK asked, how do you get politicians to listen to the scientists? I guess you just have to talk to them. Okay. We could model the effects of resource scarcity. Specific local situations could be addressed. The same platform had information gathering with a chat function, because effective information gathering is not just a matter of technology, it's really about human networks and engaging people. Dashboards provide focus, but you really just need a deep dive. And I think everyone said this. The indicators and the framework for decision making, they evolve with the situation and with the science. Everyone had a frame. This is clear. Readiness and preparedness is the foundation. Surveillance, when you're acting, is the umbrella. And the phases of prevention, detection, response, and recovery. This is my last slide. Complex challenges require effective engagement. Some of the things that I want to remember in terms of community resilience: engage everyone, all of government, all of country, all of society. Listen to the scientists, disseminate information clearly and simply. Graphs are great. Utilize all communication media. We used everything: radio, Zoom, social media, TikTok. Utilize technology, encourage innovation and initiative. Most importantly, harness and build communities. I didn't write it here specifically. I'll use Dr. Saldana's words. He at the in April 29, this last year, when we're basically trying to look at what we learned during the pandemic, he said this: when the pandemic started, I told myself, every disaster movie begins with the government ignoring scientists. I'm a scientist. I will not let that happen to the Philippines. And I think if there's anything I'm kind of proud of, is that one of the benefits of COVID pandemic is we proved once and for all to the government and to the public that listening to scientists works. And I think we created credibility for the science, which will give a great foundation for the future in terms of community resilience. Thank you.
Thank you, Professor, for sharing with us on how we can use data science and technology to build community trust during COVID-19. All right, so let us welcome our third speaker for the session of today, Professor Wu. Professor Wu is currently the Deputy Dean of Shanghai Medical College of Fudan University, the Director of Shanghai Institute of Infectious Disease and Biosecurity, and also the Director of WHO Collaborating Center for Healthy City. So during the onset of the COVID-19 pandemic, Dr. Wu was a member of the China WHO Joint Investigation Group on COVID-19, while also serving as a scientific advisor and counselor of Shanghai Municipal Leading Group for Control and Prevention of COVID-19. So during the upcoming sessions, Professor Wu will share with us her experience during the pandemic and how we can build capacity aiming at community resilience and enhance large-scale emergency response in anticipation of future health crisis. Thank you, Professor Wu.
Thank you for Chairwoman for your introduction, and let me settle. Okay. 20 minutes. I hope that I can finish this, because during the pandemic, I really myself is deeply involved and participate in the anti-epidemic process. So quite a lot of information I can share with everyone here. But now today, I would like to focus at the community resilience for the future. Here, I just show the pandemic. The curve, we know that the point I listed here for Hong Kong epidemic and the Shanghai epidemic, just to show you the time at that point. So after this, in the past more than 3 years, I can stratify Shanghai pattern in two kinds patterns. One is about 2.5 years at the beginning, and then after the huge pandemic outbreak. So it's the latent period. So what kind of pattern? Two kind of different pattern. What kind of strategy that we have during this anti-epidemic process? Here, the latent pattern, it is very lower. If you look at this, it's very lower because there is no screening test, so there is no actual report number. But I can let you know, we can estimate after the pandemic, there is about more than 70%. 70 to 75% of total population in Shanghai be infected. Okay, so here the peak is pretty high. So what kind of pattern what kind of first pattern in the period, in the first period during the pandemic?
I generate 5 words in Chinese, 早快准全暖. So for early, one thing is early detection and response. The second is rapid tracing of these infections, tracing back. The third one is keywords is precise testing and targeting at the population, especially the person who are at risk. So the fourth keywords is complete and comprehensive measures that deliver to that targeted population. The fifth words, it is the humanistic care with warm and warmest care to deliver to all these services to the residents. This is the theoretical picture that how we targeted at different people at risk. One is confirmed cases, then we do close contacts, doing the contact tracing, and then contacts to close contacts. It's really a little bit complicated, but actually we can early detection who are at risk. So using this, stratify the population who are at risk in different level. We tailored varied quarantine and testing measures. I'll give you 2 cases that happened in Shanghai. One case happened a small scale outbreak that happened in the year of 2021, in February, in January, in one community that near the Bronx. There was in that area, there's a lot of high density population be there. So within 15 hours, more than one close contact person contacts we tested, and about 3,300 people who are at risk we detected, and also 30 taxi drivers that be isolated in the designated hotels, and also more than 20 restaurants, because one person who are the indicator case who are identified as the positive person earlier, but within 10 days, he didn't say anything about their activities during the 10 days. But once we found it's a little bit late at that moment. So this investigation, I leading this investigation at that moment. So within 10 days, about within 2 weeks, we fully control that small scale pandemic. These pandemic related with hospital, related with community, and related with schools. So all these sites, you will see, we will like say these schools, hospitals is sort of expanded sites, very easier to transmit, because there was a person gathered together. We call gathered together were easily to transmit. So within this, we're using this kind of measures. We have a very rapid response and multi-sectoral cooperation, try to minimize the impact of the pandemic on the megacity. In the meantime, we also have a very good humanistic care to all persons, all these persons that if you can read the Chinese, that you will find all dogs and pets can bring them together with the people who are due to quarantine. So this is the first case. The second case is happened in that year, the 2021, during Halloween. One case was identified by the neighborhood province, Zhejiang province, and they reported this in the morning. And then if you calculate like this, it's in hours. We're taking action in hours, not in days. So we invite all the companies, Disney companies sitting together, and with the department of the government department, health sectors, transportation sectors, civil affair bureaus, and the security bureaus, all these departments sitting together to decide what is the next step. And then if you look at this, to the end of the to the 8 o'clock in the evening, we set 200 the outreach booths PCI testing be organized by health department, and all of these numbers be sampled before 11 o'clock in the midnight, and then 46 close contacts and nearly 500 cases at risk be traced. And also we disseminate all the information to the residents in the city through the Department of Education, and it say if the parents bring their child to be visited the Disney the day before and be go to have a PCR test during the overnight, and also the second day you don't ask this child to the school. In the meantime, when we finish all this PCR testing, everybody wondering where it is the tram, where it is the buses. But when they're wondering, there is the secretary, the officials from the Transportation Bureau, just to give them the direction where the buses go back home. So everything is well organized and with very good cooperation between the departments of the government. So people say that it is the most romantic PCR testing because the Halloween still was the fireworks, you see that. This is to give you a case. During this kind of pattern, we can do really, finally, we do the 5 words: strengthen, speed, precision, and warmth and happiness. So what kind of the characteristic of the pattern, this kind of pattern that is very important is we need very sensitive surveillance system. That means the case will be identified and testing in very, very early stage before they have a big transmission to the public. And very important is swift contact tracing, rapid response, especially we're using a CDC professional persons like special forces. They just put down the fires everywhere that we found. And then a very good coordination and alignment mechanism is very important. As I give you the case I mentioned, all this involving multi-sectoral cooperation and a whole society participation, of course, including a very good risk communication, all of this inside. Then the time came to the early last year. Shanghai, just followed by Hong Kong, as a big pandemic. And everyone on the website say, oh, the super scholar got followed, right? At that moment. So what is the problem? So we're just thinking about that. With the big pandemic, could we use the strategy I mentioned before during that pattern 1? Could we using that strategy to deal with such a kind of pandemic? The answer is not. The reason is the core characteristics of pattern 2 or big pandemic. This, we have the new virus with very high transmission speed. And also we have a huge number of cases, close contacts, people at risk, and also we have very limited sources if compared with the need. So many major cities, especially the mega cities, have such kind of experience that you're facing a large number or huge number need to deal with, especially the patients, and you have very limited ICU. So challenges for health system and community in such kind of pattern is you have a lack of effective testing and contact tracing system, continuous data gathering and risk assessment, huge number of cases and limited healthcare capacity, livelihood support, lack of livelihood support and health maintenance function at the community level, and also individual health awareness and also the application of novel technology. People don't, especially the elderly people, they cannot using the cellular phone, and they also don't have this kind of capacity at any time that it could be invoiced. So these kind of lack of preparedness and the capacity and coordination can lead to an inefficient response. So this is the tool. So here I mentioned from the pattern 1, we need to switch to pattern 2. So if we only still using the pattern 1, that using early screening and detection and a rapid response, all these actions we found at that moment is totally behind the pandemic. You cannot ahead of the pandemic, the pandemic. So how we deal with that? With the large scale of the pandemic. So we need to have well-stratified diagnosis and treatment system and a community health management support system. I would like a little bit go to detail about these kind of two systems. So one is, if you look at the right side, it's community health management and support system. Why I not only say health management, but including support system. The reason is it's not only the issue by health departments or primary health care center. We need community health environment assessments if we ask the people settle in their household, and we also need the guidance to professional person, especially working in the primary health care center, to the doctors, give them the guideline for stratify the patients and to monitoring the situation or the condition of the patients. And we also need the community personnel training, and we also need to empowering the individual in the community, and also the livelihood support for the family if we ask them quarantine at home, and also crisis management for emergency. And also the liabilities, clear liabilities for individual, family, and community. So this is the whole system that does need to clarify, and also need to package them together, working together and running together. But this is not only enough. This is just at the community level. But we also need a well-stratified diagnosis and treatment system. If we're only talking about in the health system, health department, we need an action plan on patient severity stratification. We have this national guideline, but it is not action plan. It is quite a principle guideline. How do you just fit in your situation, your municipality situation, or in the community? This is important. We need action plan. The second is we need reallocation medical resources and the centralized dispatching. This is extremely important, because every time if the primary health care center workers or the doctors, they say we have a patient at a severe situation or condition, we need to send it to the general hospital. Where we need to go, where have the ICU beds? You don't know. So centralized dispatching is very, very important at that moment. And also we need to establish the criteria and clear criteria and the procedures for patient transfer, where they need to go according to the like the first aid. Here I want to point out, in mainland China, we stratified the hospital as the first and second and third, different kind of level. The first level is the primary health care center. The third level is the general hospital normally. So when we're talking about the stratified diagnosis and treatment system, we directly link to that kind of stratification, but it's actually not. If we're talking about the emergency response, this sort of well-stratified diagnosis and treatment system means similar to first aid. It's not only, it's totally depending on the situation, the condition, what the severity of the condition of the patient. So this is important. These criteria and the procedure need very, very clearly to stratify and also to let every doctor know about this. And that will help the patient to quickly transfer to the right level. And also training for all level medical personnel. So this is the whole key issues from the community and also the health system to the support. Within this, if you look at the coordination and aligning mechanism within makes all the runnings mostly. If without this, what I want to point out, the mechanism is key issue. And also the multi-sector cooperation and whole society participation is extremely important. If you just look at the right side and the left side running, it didn't work very smoothly. So this is important. I wanted to go down this in detail. So key area for future preparedness, I would like to leave the sort of like the sometimes we always have these kind of rely on some infrastructure. We have set up sort of emergency response office or department in different kind of level. So it is rely on the infrastructure. But I wouldn't say that because we already have that. We have the equipment, we have hospital, we have the community primary health care center. But that is not the most important in the future. I think the very core issue in the future is under the political willingness, we need a very clear and quickly decision making. And we also made the coordination among the departments, among the different sector, multi-sector and government system, but also in the society. This mechanism is important and all we call up-down linkage mechanism. The other one is capacity building, especially at the community level, and also empowering individual is equally important. The last one, I think, the well-stratified diagnosis and treatment in medical institution is also important. I mentioned this already. So the final one I would like to say, the core essence of emergency response is the given authority to reallocation of social resources in an urgent situation. It's not just set up a department, have several staffs be in the emergency response office as enough. It's totally not enough at all. So we need to look at the mechanism. We need to the whole system, how the whole system is running. This is the essential importance. So thank you.
Thank you very much, Professor Wu, in sharing with us her experience of engaging the medical personnel and the community in managing the COVID pandemic in Shanghai. For our last speakers of the sessions for today, I would like to invite Dr. Chu from the Institute of Development and Human Security at the YEOH Women's University in Korea. Dr. Chu's research interest lies in human rights and governance, health policy and resilience. The research focuses on human rights and resilience of vulnerable groups under various types of disasters, including climate change. So drawing from the findings of her qualitative research in South Korea during the COVID-19, Dr. Chu is going to discuss the implications for components and relationships of community disaster resilience under COVID-19 pandemic in South Korea. Thank you.
So, good afternoon. It is my great honor and pleasure to be invited to this prestigious event as a speaker. I'm Min-ji Ju. I'm a senior researcher at the Institute for Development and Human Security at the YEOH University, so South Korea. And today I would like to share with you part of my study conducted last year, titled Implications for Components and Relationships of Community Disaster Resilience of the COVID-19 Pandemic in South Korea. So why should we care about the concept of community disaster resilience? It is because disaster resilience and community resilience are strongly correlated with each other, both conceptually as well as empirically. And as you know, all disasters are just occurring locally. So then what do you mean by community disaster resilience? It is the ability of the community to harness both the capitals and response strategies given in a disaster and lead to a better situation than before throughout the absorptive and adaptive and transformative capacity. So as all of you already know, the Korean COVID response system has been central government driven, which was really strong. For example, we did a 3T model, which refers to test, traces, and treatment. And as you can see from the graph, we could keep relatively low confirmed cases as well as mortality rate. And also, the Korean government really focused on vaccinations. So, consequently, we kept higher vaccination rather than other countries. And however, those were just, I think, those were just the examples of the outcome-based resilience. And however, for today, I want to focus on and share with you a slightly different aspect of the Korean COVID model, process-based resilience, such as community-level efforts, especially non-profit sectors in the communities. So I hope to draw critical implications related to challenges faced by communities throughout phases of the pandemic and provide insights for facilitating their community disaster resilience. So in line with the goal, I aim to examine, reshape, or refine components of CDR based on the response process of local government and nonprofit sector community members in South Korea, as well as to explore the relationship between CDR components, which is composed of capitals and attributes during COVID. So as I told you, there are core components of CDR framework based on previous resilience study, which are capitals and attributes. And capitals are antecedent conditions and somewhat inherent capacity, which features more static and quantitative. So based on the previous literature, I I especially focused on the BRICS model, which encompasses institutional governance, infrastructure, community, and human well-being variables. And as for the attributes, which means the response strategies and adaptive capacity, which features more dynamic and qualitative. And as for the attributes, I selected 4R's framework, which indicates robustness, redundancy, rapidity, and resourcefulness. So since many resilience studies selected counties in the US as the unit of analysis, I also selected 4 cities that have more than 1 million citizens in South Korea, which are very similar to counties. And as for the research participant, I interviewed a total of 42 people who have been actively involved in the COVID-19 response. And as for the public sector, I interviewed with local bureaucrats and public health center epidemiological investigators and research institute researchers. And as for the nonprofit sector, I interviewed with community social security consultative body members, as well as community welfare center workers. So I used ground theory method and paradigm model specifically, and I conducted in-depth interview face-to-face from March to September last year. So the first main point I want to show you is that even within the community disaster resilience framework, sectoral differences in capitals and attributes both have been identified that indicate higher performance from the public sector and nonprofit sector, respectively, in South Korea. So in terms of institutional or governance capital, utilization level of disaster response decision-making mechanism was really important for especially public sector, as they stressed the frequency of central and local disaster countermeasure headquarters meetings. And level of information sharing system among organizations are important for both sectors, public and nonprofit. And they commonly said that even though a great deal of information has been collected and managed about confirmed cases, just a little effort has been put into an effective information sharing system during COVID, which in turn increased the workload of local first responders. So one epidemiological investigator said that how inefficient it is for one person just go in here system and go to other system to manage one patient one a day because they just were not connected. And also partnership activation with citizens was an important component for nonprofit sector. And residents who had been fostering community connections actively collaborated in identifying and supporting local vulnerable or marginalized households in the COVID crisis. And in terms of infrastructure capital, number of disaster response that was important for public sector, but I could slightly refine from existing resilience variable that they stress the importance of caring personnel as well as medical personnel. So one other epidemiological investigator said that pointed out that nursing homes, daycare centers, and all sorts of other things that we haven't really thought about. People have nowhere to go, and who will be going to follow them, put them in isolation and take care of the recovery? I think that's the biggest problem going forward. In the meanwhile, in terms of community capital, citizen disaster training was important for nonprofit sector, especially. So they said that capacity training for nonprofit members, including the elderly, was a crucial prerequisite. So one civil member said that considering their relatively older age, it is necessary to conduct these educational sessions annually or regularly to ensure they do not forget. And in terms of human well-being capital, Citizen awareness and participation in abiding by disease control rules was important for both sectors. They precisely stated and cooperating with the investigation was also a crucial factor in minimizing risk of COVID within the community. And I want to lastly I want to mention one thing: the existing variables for measuring resilience. Maybe I think we need to reconsider the inclusion of this variable pre-retirement age as for measuring resilience. Because from the interview data, I found that many members, particularly the elderly members, contribute to their community as well. So even though they are vulnerable to COVID-19, they still played a crucial role in their community in responding COVID. So one civil member mentioned that what I found unique is that all the members of the cooperative body are actually quite elderly. In fact, they are considered vulnerable due to the infection situation. However, they actively participate in the programs for the community and their neighbors regardless of COVID. So what I found was that in a nutshell, even in this existing single or one framework, I found the sectoral difference between public sector and non-profit sector in terms of capitals in the context of COVID. For attributes, I could refine the definition of the robustness to at first to respond stably as well as sustainably. So both public and nonprofit sector stressed sustainability aspect, maintaining the response while gradually normalizing the workload of local responders has emerged as a key response strategy. And they also both stressed setting criteria. And as for the redundancy, I could also refine the original definition to ability to utilize existing resources that exist even before COVID-19. So during COVID, both public and nonprofit utilized organizations or networks that were originally operated for different purposes. So one public bureaucrat said that originally there was just crime prevention patrol, right? Just regular patrols. However, we have utilized them for things like dealing with COVID-19, like promoting vaccination and promoting testing, etc. And as for the rapidity, while reconfirming this definition, I found that the focus was slightly different between public and nonprofit sector. While public sector stressed taking prompt measures such as preemptiveness and agility, nonprofit sector more stressed context-sensitive adjustments of coping strategies, which refers to flexibility, such as utilizing the advantage of online interaction for contingency planning. And lastly, in terms of resourcefulness, while reconfirming its original definition, I also found that the focus was slightly different between two sectors. So while the public sector stressed mobilizing the whole government's resources, like effective arrangement of resources more, nonprofit sectors stressed linking resources, and they also stressed low redundancy. And one nonprofit member said, I'm close with the village leaders. I used to be a village leader and also participate in the resident self-governing committee as well. So I think there's the concept, it can be the concept of role redundancy, that one individual can have several roles to and that can help linking resources in the community. So again, I found somewhat sectoral differences between public and nonprofit sector for the attributes in the CDR framework as well. And the second point I want to mention is that capitals and attributes in the community disaster resilience framework were assumed to be fixed according to the previous research. But during the COVID, they evolved with more dynamic and complementary interactions. So let me just briefly cover the relationship between capitals and attributes. Based on the interview data and the Korean government literature, I set the absorptive capacity from January 2022 to August January 2020 to August 2020. At that time, I found that capital was mattered, capital like resources in the context of COVID, but that the capital's insufficiency was inevitable. Then attributes, which means harnessing resources, and attributes could appear when capital was not sufficient. For example, while the number of personnel was insufficient, as for the public sector, all department officers were dispatched or relocated to COVID-19 response work, which means to resourcefulness. And as for the nonprofit sector, members tried to use resources having existed before COVID-19, which refers to redundancy, or actively sought cooperation with other organizations, which can refer to resourcefulness. And the second stage was adaptive capacity, and I set the period according to the data and government document, and I set the period from August 2020 to January 2022, when the Alpha and Delta viruses come in. At that time, the relationship between capitals and attributes is dynamic through a constant feedback process. For example, for both public and nonprofit sectors, development of information sharing system, which can refer to capitals, affected COVID response strategies, which mean attributes, and education and training capitals positively affected strengthening their expertise, which means their attributes like robustness, and that consequently lead to an effective response in the community, even with fewer people, which again means capitals. And the last stage was transformative capacity, and I set this period after Omicron virus, so from January 2022 to September last year. At that time, capitals and attributes evolved throughout absorptive and adaptive previous periods, and attributes that function capital utilization capabilities could be more important than capitals this time. According to interviews, many interviewees, like both public and nonprofit sector, they commonly said that number of response personnel, so capitals per se, is not enough for response. The experience and strategies from COVID-19 much more matters. So implications are that sectoral differences in existing community disaster resilience components have been identified. And even in the strong government-driven response process in Korea, the role of the nonprofit sector at the local community level was vital and complementary. And we need to focus effective collaboration, since both sectors can function complementarily with each other. And we need to reconsider the much more dynamic relationships and interactions between capitals, which means resources, and attributes like coping strategies in responding this type of long-term and incremental biological disaster. And much more needs to be done to refine the economic and environmental capitals as well in this in the future study, and also quantitative analysis of this model will be needed. And I think we need to test in other regions about this model or other context or other type of infectious disease disasters. And I think also we need to explore the Asian model of resilience framework. Once again, thank you for having me. Thank you very much.
Thank you very much, Dr. Chu. We want to thank all the speakers on the stage for very brief discussion sessions. Because of the time, we may only be able to have. We have 2 questions on the floor. Okay, Professor Young, please.
Thank you very much. Most interesting presentations. I have a quick question for Dr. Chu. It's very interesting, your paper on community resilience, but one of the variables that you did not consider was the role of the private sector. Because you talked about the interaction of the public sector and the not-for-profit, but some of the resources may also be in the private sector. I think during COVID, the experience has been in the pandemic, the private for-profit sector worked very closely with the not-for-profit in the community. And I think in many countries, the resources, the partnership was quite important in terms of coping, as you quite rightly said about the resourcefulness and the capitals. Did you factor that in your model?
Professor, thank you. Firstly, thank you very much for your question. And yes, I think, to be frank, I think this is one of the limitation of my research. And yes, I think also in the context of South Korea, as you mentioned, that the private sector is really important to considering in this resilience model, because we have around 90% of private sector in our public health system context. So I need to further figure out if private sector involved in this framework, and we can adjust we need to test if we can adjust these variables I found. Yes, thank you very much.
Thank you very much. Any questions from the floor?
Thank you. I'm Cindy from the Chinese University of Hong Kong. I have one question for Professor Wu. As you mentioned, like in China, we have 2 patterns, but I'm just very curious about the transformation period from pattern 1 to pattern 2. And at that time, I remember it's a short window time. And I just felt at that time from the social media, we can say the public cannot fully understand the decision making. And we got a lot negative comments from the social media. So my question, do you have any suggestion or comment about the short transformation period? Like how to make the public more be aware of or be fully better understand the decision making? Thank you.
Yes, the most difficult question for me. Although I'm fully involved and deeply involved in that process, but it is still very difficult for not only for the professional persons, but also for the local government. Every different departments fully understand why we need transit these kind of patterns, or we change the strategy. It's quite difficult for the person who worked in different departments
besides outside the health department, because they don't have these kind of medical background. Ask them to understand the rapid transmission of the virus, especially the Omicron. It's very difficult because we are epidemiologists and we understand this kind of curve that's going up very quickly. And we can understand the hidden cases and transmission under the surfaces, right? But you ask them, everyone, to understand this very difficult. This is one thing. That is why nowadays we in our university, we start to a training program or workshop to improving the capacity of the government officials have these kind of capacity. This is first, understanding how to understand it, right? Understand what are we talking about, the professional person talking about. The second difficulty is people never facing such kind of a huge pandemic, huge number of cases suddenly, because in the past we just a few cases reported in very short period, but in that period it's over 10,000 cases every day. They totally no idea about that. So that suddenly they found, wow, they got a shock. So these kind of preparedness, it is written in the paper, but never have this kind of rehearsal be done in the past. So they don't have such kind of what we call the implementation capacity to deal with that. This is second. The third issue I think is very important is also including the decision making. You asked this person to making a precise decision at right time. It is also very difficult because at that moment, the impact that we can see is very, very large impact, and the long-term influence for that decision. So making decision is important, but also very difficult. This is third. The fourth is people still have this kind of we call dream that CDC person will deal with that. So they are not everyone that's participating in that period, including the media person. So disseminate the right message to the public. Also do a very good risk communication with everyone, with the public. Also as a problem, I should say. So that all these problems put together. So the result, you already see that. But after that, today, in post-pandemic period nowadays, I think it's important is we need to thinking about what is the most important. So today I mentioned we always like to build something hard. We call hard the infrastructure, the department. We build some new hospital, have more beds, and buy more machine for testing, sort of this. But the very important it is this, how about the soft, the mechanism, the capacity, the communication way? That is something nowadays we need to pay much more attention on this. If we neglect this, one thing could be for sure, that is next pandemic is coming. And we hope that we are not still repeat the pattern. We don't like this. So that's why we're coming here. We have this conference, and thank you for your question.
Okay, that was the last one. Thank you.
speak loudly. Thank you. I have one more question for professors from Philippines and Hong Kong, the Professor Cho and Professor Harina. Thank you so much for your guys' amazing lectures. And my question actually is, when we're talking about community resilience, we mainly focus on the community engagement. So nowadays we have more technologies to help public health professionals and public health authorities to tracing, surveillancing, like what we already discussed, the QR code and the vaccine passport. So my question actually is, in the past several years, communities, or we see the public may already burn out, or we tired about the keep healthy QR code. So how could we do to deal with this question to prepare for the next health crisis? Thank you.
Maybe I'll try to answer that question first. I think we are not fighting a pandemic in a vacuum. We are fighting a pandemic in the community. And the very important point is to gain the trust of the people in the community. Because other than public sector, non-profit sector, private sector, I think everyone has a role to play. And for governmental authorities, you need to gain the trust of people before anything can work. And that's why I think essentially you need to prepare the people, need to promote the message of they need to safeguard the health in advance of the next pandemic before it strikes again. And therefore you need to educate the people as well, and to gain the trust, to believe in the government, to believe in the health authorities, that they can implement effective measures to safeguard the health of the people. I think that is the most crucial thing.
I think I really want to explain that it's not just the pandemic. When we talk about resilience, we're talking about a focus on health and a focus on being able to respond correctly and knowing who to trust. So you have to remember, I live in the Philippines. We are a nation of disasters. We live on the ring of fire. We have more volcanoes, I think, per square meter than most countries. We have earthquakes all the time. We have typhoons all the time. Nobody panics when a typhoon is coming tomorrow. Nobody panics when there's a flood. We know what to do. People are used to disasters. What was different about the pandemic was it was so immediate. And I think that was for the country, kind of a wake-up call. I think what we're taking away from the pandemic as a country is that we learned that we could work together. We learned that we could trust government. We learned that if we work together, we can get things done. And I think that was very valuable for the country as a whole. And I think right now the country is looking at health maintenance as opposed to fighting a pandemic. It's about working on the non-infectious diseases. Now people are thinking about how do we fight obesity, how do we fight diabetes, so people are now in mental health. And I think what we need to do as a community in terms of engagement is to just keep remembering that it is about health, it is about working together, and it is always going to be about listening to the science.
Thank you so much. Thank you very much for the very passionate sharing in the afternoon. And thank you very much for all of you here today. So I'll pass the mic back to Nancy to wrap up the conference for today.
Thank you.
Thank you, Dr. Lai, and our fellow presenters for finishing strong. We're nearing the end of the, sorry. Now it's for photo taking session.
Let's wait on that. It's not coming down.
Oh, okay.
All right.
Okay, 1, 2, 3. Okay, please look ahead. 1, 2, 3. Then.
And we're nearing the end of the event, but before we go, we'd like to announce the winners for Best Posters competition. We would first like to thank all the participants for their contributions in this contest. And we would also like to thank Professor Chung-mau and Professor Laksono TRISNANTORO for being the judges for this competition. Now, let's first invite Professor Chung-mau onto stage to present the prize for the third place for Best Posters. And the third place goes, drum roll, Ms. Lai-ling from the Department of Psychiatry and from the University of Hong Kong. Her poster title is Health and Socioeconomic Demographic Characteristics as Predictors of Post-Acute Sequelae of COVID-19 over a one-year period and the association with well-being. Professor TRISNANTORO is already here. So we'll announce the winner of the second place. The second place for Best Poster goes to Professor Wong Eliza Lai-ling from the Faculty of Medicine, JC School of Public Health and Primary Care, YEOH. Her poster title is Social Support, Resilience, and Mental Health Among 3 High-Risk Groups in Hong Kong, a Mediation Analysis. Thank you. Now let's invite Professor EK onto stage to present the prize for first place. And the biggest winner of the best poster goes to, oh, I hope I pronounce this right, Dr. Puspandari Dia from Faculty of Medicine, Public Health and Nursing, Universitas Gajah Mada. Poster title, Cost Analysis for Tracing on COVID-19 in Indonesia. Congratulations.
Okay, 1, 2, 3.
Congratulations to all the winners. Professor Yo, please remain on stage for your closing remarks for this fruitful day.
It's been a very long day, so I'll be very brief. I think you all agree with me that we really had a marvelous day today. We're so appreciative for all the visitors that came to Hong Kong. You've really enriched our discussions. I think we had very broad discussions from policy to operations to community, and a very, very broad spectrum of experiences. I think it's given us further thought for thinking, and I think also Professor Laksono mentioned about the future work that we can do together, right? So thank you very much for your contributions, and I hope you enjoyed it as much as we did, and that you have benefited from it. Thank you.
Thank you, Professor Yo, for your participation. We'll see you next time. Goodbye.
For the speakers for going for dinner, there's a shuttle that will take you around the university as well. Because the Chinese University, the campus is about 6 kilometers away, and it's just next to the restaurant where we're going to have dinner. So it'll be quite useful for you to just have a look at our campus, because this is not our main campus. This is part of the hospital. 你有車啊？你自己唔該晒。我哋會早少少嚟。阿 Ronald 話會早啲，咁我哋去嗌啲酒去飲，唔使，因為大咗。OK。幾多點到啊？你哋？ 6點半啊嘛，咁啊，我哋我一陣去6點鐘會出發。你早啲去得㗎，冇問題。Otherwise都唔知去邊度。係啊。
我都喺呢頭。
唔係係咯，你 anytime 我哋6點4到會去到，6點3就去到。Thank you very much。唔該晒，好好你講得。Thank you very much. It's a great paper. Right, very interesting. Right. No, it's very good. Yeah. Right. So you. Okay. No. I just thought it was important, but your work is very, very interesting. I enjoyed it very much. Thank you.
老闆，你好啊，你俾我睇，得啦，我哋收啦。俾邊個㗎？我哋借㗎，係咪啊？即係我要 hold 住，做咩做啊？Kerry，我哋㗎，係咪 YouTube 㗎？
要還翻佢幾多啊？200蚊一日啊！
嗰度仲有2支啊，加埋佢先啦，擺喺個架度先。